Yes.
Nishan?
Yes,
so
okay.
we are live now.
Go ahead, start.
Okay. Good evening, delegates and participants, and good evening, all the doctors, for joining Shield Connect. Thank you for joining, everyone. So today we are starting this webinar, E-Classic for Clinicians, PPH Skill and Drill, which is organized under the aegis of Societies of Karimnagar, Madurai, Salem, and Adur. So let me introduce our MOC before we start the session. So our conveners are Dr. Shailaja Naluri from Vijayawada and Dr. Ayushi Agarwal from Gorakhpur. Dr. Shailaja Naluri is a civil surgeon specialist, insurance medical services in Vijayawada. Ma'am has done graduation from Osmania Medical College and MS from Gandhi Medical College. Past treasurer and the secretary of VOGS, treasurer of Vijayawada chapter of Indian Menopause Society, and delivered lectures at IMA Vijayawada, APCOG, Nellore, and Yuva Foxy South Zone 2018 in the organizing team of first annual APCOG at Vijayawada, in the organizing team of Yuva Foxy South Zone 2018, and member of Foxy No to Wow committee. Done 35 Dira school programs through Vijayawada Society, and field of interest is PCO and high risk obstetrics. And now let me also introduce our other convener, Dr. Ayushi Agrawal. Ma'am is ex-senior resident at AIMS Gorakhpur, presently junior consultant at Jeevan Jyoti Hospital and Medical Research Center, Gorakhpur. So I will hand over this session to Dr. Shailaja ma'am. Thank you.
Thank you, Nishan, for that introduction. Welcome to all the esteemed faculty and delegates to this E-Skill and Drill PPH workshop, where we have very esteemed faculty who will be showing us live how do we treat postpartum hemorrhage. Dr. Sadhana Gupta has been conducting such webinars continuously every month, 2 or 3 webinars regarding cesarean sections, PPH, and fetal medicine workshops. She has been continuously traveling, speaking to people physically and speaking online also. Can we have the CV slide of Sadhana madam, please? We'll have the lamp lighting first. Dr. Sadhana Gupta, who is our key organizer, has been the co-chair of SAFAG Non-Communicable Diseases Committee. She doesn't need an introduction. Actually, we have been knowing her since such a long time. She has been Foxy representative to SAFAG 2018-21, has been the vice president Foxy 2016, ICOG governing council member plus from 2015 to 21, with receiving the best governing council award in 2021. She has been the corresponding national editor and peer reviewer of Journal of OBGYN India and SAFAG. Foxy past chairperson, Safe Motherhood Committee with Dr. Mehru Dara Hansotia Award for Best Committee Activity. She has thrice represented the country in WHO on key women health issues. She has been the 3 times recipient of Korean Award for Best Scientific Research Paper.
It's okay, Shailaja.
Madam, it's such an exhaustive CV. She doesn't need an introduction. Actually, I hand over the session to Dr. Sadhana Gupta.
So thank you, Shailaja. And
Sampath Kumari, madam.
Good evening, Dr. Sampath. Please rename also yourself. Good evening. Please rename Dr. Sampath yourself. So a warm welcome to our dignitaries, Dr. Sheila Mane, Dr. Sampath Kumari, office bearers of Karimnagar, Madurai, Salem, and the Adur Society, Dr. P. Chandramati, Dr. Radha Kaluri, Dr. Jyoti Sundaram, Dr. Kalpana Bala Murugan, Dr. G. Jaimala, Dr. L. Shram Gava, Dr. Prasanna Kumari, and Dr. Saipri Papan. Thank you very much for finalizing the date and be able to have this workshop today with all Karimnagar, Madurai, Adur, and the Salem Society. So this is E-Classic for Clinician. Actually, why it is a name and why this is the program, because today we have so much of ever-changing evidence and ever-changing issues and the ever new upcoming challenges. And with this, our clinicians get really confused that what they should do, because it is changing every day. So the name Classic for Clinician, that the basic teaching and basic concept of medicine remains the foundation stone of our day-to-day clinical practice. It also always never fails to give the best treatment strategies as well. And we have to hold that basic and the classic teaching along with the recent updates and the professional bodies recommendation, so that every clinician, every OB/GYN who joins this webinar has a clear roadmap what to do in any managing any situation. So postpartum hemorrhage is something which we all know, our all faculty, guest speaker, everybody will be talking about it, and it always remains a very, very important challenge and always contributing to a lot of maternal criticality, maternal mortality, a lot of medical, legal, and social issues. So this is the subject which is always there, a nightmare for OB/GYN, and in every setting. What is our mission is the saving mothers everywhere. So every city, wherever women reside, whatever is her socio-economic, religious status, we have to save the women. And that's why all the key faculties, all the people are joining together for making this mission possible. So with this a warm gratitude to everyone, it is a great pleasure to have none other than Dr. Sheila Mane as a chief guest. She has been kindly accepted, and she is there despite her her sister is not well. So thank you, Dr. Sheila Mane. So she is the currently DMB faculty at the KCG Medical College Hospital, Bengaluru, ICOG vice chairperson. She is elect President Bengaluru Isopap Society. She has been the Safe Motherhood Committee chairperson of FOXI with the Best Committee Award. And actually, I have learned whatever I have done as a chair Safe Motherhood Committee and onwards, a lot of things I have learned from Dr. Sheila Mane, the way she has worked so passionately when she was chairperson as well as the vice president FOXI in 2014. So more than 2 decades working for FOXI. She's known as PPH lady all over. So it is a great pleasure to have Dr. Sheila Mane in PPH workshop, a seasoned teacher, recipient of Best Teacher Award by Dr. B.R. Ambedkar Medical College, Best Society, Dr. Mehrudara Hansoti, and served as a national facilitator at Eurocent Health. So welcome, Dr. Sheila Mane, and we wish to hear you.
Just a minute. Yeah. You want me to address now?
Yes, ma'am.
Yeah. So good evening, everybody. It's very happy to be here today, and it's a nice amalgamation. I can say that the societies of South and faculty from almost all over South as well as North is taking part in this e-learning, that is the skill and drill for PPH. And as all of us, we know that it is still a necessity. I think whatever we are teaching and educating people is still not enough, because still the awareness has to come that how they have to act at the time of emergency. So I think when we talk about skill and drill, that is the one which will definitely enlighten everybody and will help to spread this knowledge. And we have an esteemed faculty, none other than Dr. Samartharam here, which I had an opportunity to invite him to Bangalore to KC General Hospital and had a live video demonstration. And I must tell you that I mean, seeing is believing, and it's a great invention, I must say, of this century, particularly for PPH. Okay, so it is great to have him again in this webinar today. And all of us, we know Dr. Sadhana's passion as and I know more because I was also Safe Motherhood Committee chairperson. She was also Safe Motherhood Committee chairperson, and both of us have worked together to this cause. And it's very close to our heart. And I think all the time, I think we will be working for this cause till we are there in this world. And I appreciate all of you for joining in this evening for this. The societies, I think Karimnagar, Vijayawada, Madurai, Adur, and the faculty which we have from north as well as from south. And once again, I congratulate all of you for conducting this and wishing you best of luck for Dr. Sadhana for her future endeavors. Okay, and thank you for the invitation. And I also would like to see that Dr. Sampath Kumari, our current Vice President from South Zone, is here. And she is also a very active person. And now as a Vice President also, they are involved in so many activities. And it's nice on her. It is nice on her part that she has joined here today. So I think on behalf of Sadhana, I welcome you all and I congratulate you all for going ahead with this e-class of skill and drill session on PPH. And thank you once again for the invitation.
Thank you, Dr. Sheila Mane. Thank you for all your wonderful work. So, and we welcome our guest of honor, Dr. Sampath Kumari. We were just yesterday, what we say, a few 5 days ago, we were together at Chennai. So, Dr. Sampath Kumari is known in Foxy for her perseverant, apparently very simple person, but what amount of work she can do, it is just, you have to see. Again, you have to believe when you see that she is working so much, and she has already done with the 2 or 3 conferences in her vice presidency area. So Dr. Sampath Kumari, for formal introduction, she is Vice President Foxy this year, Senate member TN Dr. MGR Medical University, National Corresponding Editor of Journal OB-GYN of India, Founder Secretary TNFOG at the Tamil Nadu Federation of OB-GYN. She is working so continuously, so tremendously. We all enjoyed TNFOG conference just few months back at Chennai. Retired Deputy Director Institute of OB-GYN, MMC Chennai, President Board of Studies, OG, TNR, Dr. MGR Medical University, and as a chairperson, Foxy Adolescent Health Committee, her work was mammoth, immense, and multifaceted. We always remember Dr. Sampath Kumari's tenure as an Adolescent Health Committee chairperson. First ICOG Distinguished GC Member Award. So this is an award which we share together. So it is another strong bondage with us. And a chairperson, Women Wing IMA Chennai South, and the National President Awardee of IMA and IMA TNSB Award. Great to have Dr. Sampath, and everybody is looking forward to hear from you.
Thank you, ma'am. Thank you for the nice words. Definitely, it is the need of the hour. That too with the PPH lady as the chief guest. Dr. Sheila Mane, with wherever we see, I don't know how many cases of PPH Sheila Mane madam is doing in our hospital. Really, she is the master of PPH. Sadhana madam, like that, when she was the Safe Motherhood Committee chairperson and the book she has released, you are doing a wonderful work. We will hope for the best in future also for you. Now the topic is PPH. You have taken all medical management, surgical management, and the mechanical management. That is the SR cannula. Now it is used everywhere. In Tamil Nadu, all the medical colleges, government has supplied that SR cannula. The same person is giving the talk on SR cannula. Really, it is the need of the hour, and the panel with case discussions. I think it will be useful to everyone. So really, I am happy that our TNFOG is involved with all other societies from north. Always it should be a bonding. North or east or west or south, all should be united and work for the same cause. Anyway, thank you. I wish all the best for the success and all the best for Sadhana ma'am. Thank you.
Thank you, Dr. Sampath. Thank you very much.
Thank you, madam and Sheila madam, for that address. We always look up to you. You have been doing great work. Nishan, can we have the CVs of next chairpersons, please? Our first session is the keynote address by none other than Dr. Sadhana Gupta on resuscitation and medical management in PPH. Dr. Prasanna Kumari and Dr. Jayamala are chairing the session. Dr. Prasanna Kumari is the former professor, Government Medical College, Trivandrum, now consultant obstetrician and gynecologist at Lifeline Multispecialty Hospital, Adur. She is the president of Adur Gynecological Society, author of the book Postgraduate Gynecology. She was awarded WHO Fellowship in 1991. She has been the past president of Kerala Federation of Obstetrics and Gynecology. And Dr. Jayamala CV, please. Dr. Jayamala is the consultant obstetrician and gynecologist, infertility and gynec laparoscopic surgeon, and assistant managing director, Rainbow Hospital for Women and Children, Salem, the present president of OG Society of Salem, and she has many academic works to her credit. Jayamala madam could not make it. She is held up in an emergency. She'll join as soon as that emergency ends. I hand over the first session to Dr. Jayamala madam and Dr. Prasanna Kumari madam.
Yeah, Dr. Prasanna, yes. Dr. Prasanna and Dr. Meenakshi will be chairing. Sharja.
Prasanna madam, are you there? Yeah, Prasanna Kumari madam, please. Prasanna madam, we can't see your video and can't hear you. Madam, shall I introduce you and start the session?
Yes, Dr. Prasanna. Whatever, yes, we can go ahead. Or then Dr. Meenakshi. Dr. Meenakshi will. Dr. Meenakshi can.
Yeah, Dr. Yes. Sundara Meenakshi is done her MBBS from Government Stanley Medical College and MS from Sri Ramchandra Medical College Research Institute, and has been the gold medalist and best outgoing postgraduate in the year 2003. She has presented various papers in AICOG and Yuva Foxy. She is trained in colposcopy and tubal microsurgery. Worked as assistant professor in Salem Government Mohan Kumaramangalam Medical College and Hospital, and is right now the consultant in Sri Meenakshi Women Care Clinic, Cream Specialty Hospitals, her fields of interest being obstetrics and fertility medicine. I hand over to Dr. Sundara Meenakshi for conducting the first session, the keynote address of Dr. Sadhana Gupta. Please unmute yourself, Dr. Sundara Meenakshi. Yeah, please go ahead.
Good evening to all senior professors, and it is my great privilege and honor to be a chair for to our great ma'am, Dr. Sadhana ma'am. She has done her wonderful achievements, and she has created the roads for us as proper educated women. Being doctors, we are born to serve even to the villages where people struggle, and still in India the risk of postpartum hemorrhage is going to be, it's almost now 38%. So ma'am has got so many awards and achievements, and I seek her blessings, and it is my privilege to introduce ma'am. Ma'am, over to you, ma'am.
Thank you, Meenakshi, for loving word. Dr. Prasanna is with us. Dr. Prasanna, can you, if you talk, that we can see that it is, your audio is on or not? Should
Video is also not visible.
So I will be going for my talk on medical and the first line management of PPH. My slides are visible.
Yes.
So first of all, I owe a big gratitude that in my 30 years journey in Foxy, it was just in last week, I was at so many loving places at Chennai, and this is the Sri Rangi temple where I was. So while we actually work for saving mothers, we work for our fellow OB-GYN, we reach to the divine destinations also. So there are so many blessings which comes to us, which are bestowed on us. And I bring greeting from land of Buddha, who says we can never obtain peace in the outer world until we make peace with ourselves. So with this, I will be going ahead It is a simple topic, actually, the resuscitation and medical management. Most of all of you are well versed about it, but it is important that if we take it very, very coordinated way, in a very methodical way, most of the PPH can be managed by this first golden hour, resuscitation and medical management. So PPH, we all know, our chairperson, guest of honor, like Dr. Sheila, Dr. Sampath said that it is contributing to 30%, 30 to 35% of maternal mortality and criticality. And what is the conscious picking? That Africa and Asia, especially the India, is contributing to a larger number of maternal deaths. But what is the clinician perspective? It is bound to occur in 2 to 10% of deliveries, out of which 1 by 1,000 can be massive and life-threatening. It is a long-term scar on the woman's health, woman's family life. A lot of criticality can happen when we are dealing with PPH, obstetrical hysterectomy, ICU admission, massive blood transfusion, which in category of the near miss, and it is a lifetime scar for the obstetrician as well. So it is India is still the obstetrical hemorrhage and PPH contributing to 35 to 56% of the maternal death. And what is the concern for us? That PPH, we can lose the patient in rapidly in a short span of 1 to 2 hours. So when you face the PPH, it tests our leadership, our composure, our character, and our functioning of health system, and the skill of health worker, what team we are making them to deal with the situation, because it is so many times often unpredicted, present like a thunderbolt, and we have a lot of new upcoming causes for the PPH. So still we have the anemia, 3 delays, inadequate like quality antenatal care, that is important, but we have all the issues which the developed world is facing, that the pregnancy with myoma, obesity, medical comorbidity, and many patients on the coagulopathic anticoagulant drug, as well as the hereditary coagulopathy. So what we want to achieve in these workshops, first of all, we have to take all measures to prevent the life-threatening PPH, a good decision making among obstetrician and gynecologists, because it is the thing when we manage the PPH with success, it is a confidence boosting. But if we lose the patient, it is a lot of demoralizing effect, long lasting on the obstetrician and team. So what can be the what can be the implication when we do the suboptimal management? It can lead to the like a impaired well-being of mother, neonate, family, and obstetrician, and a lot of political, medical, legal, media, and the social issue. So at the tertiary care, now today we are very fortunate that our government is having a lot of political will, and the South have done too well to reduce the like maternal mortality and the criticality. Yet it is important that at every place, when the patient reaches to us in a hospital, we have a prompt measure. So can we prevent PPH? It is very, very important. So first thing is a good risk assessment. So we know what are the risks. It is the PPH in the previous delivery, low-lying placenta, suspected placental abruptio, preeclampsia, grand multiparity, patient with a coagulopathy or anticoagulant. Important thing is that we take a good time. Our nurses, our residents take a good time in the risk assessment. And when there are risk assessment is there, we have to flash on the antenatal card with the red or the blue mark and counsel the family that your patient can have the PPH. So you have to select the right place for the delivery. And wherever you go for delivery, it may be PSC, it may be CSC, show this card that this patient is having the risk factor for the PPH. So they act all preventive measure and organize all the things so that they can deal with the possibility of the PPH. So something is like knowledge turning into action. Now, the second thing in the prevention of the PPH is the active management of third stage of labor. Right from 1988 to 2012, we have come a long way. And now the administration of oxytocic agent within 1 minute of birth of the baby is considered the most important arm of the active management of third stage of labor, because it reduces risk of PPH, severe PPH risk reduction, need of blood transfusion, decreased risk of anemia, and decreased need of the additional uterotonic medication. So now the question is, which oxytocin? So what we think when the lot of things which some people are using prostaglandin, some people are using Bithargine. So that point has to be very, very clear that the choice of drug is either oxytocin, simple oxytocin, or the long-acting oxytocin, that is carbetocin, which has got absolutely no contraindication, no effect on the maternal vitals, and no side effect as well. Misoprostol many people are using, but I like to emphasize that it is a second choice drug. Side effects can be shivering, vomiting, and it has been proposed as a drug for the active management of third stage of labor in the community setting or when the patient has no access to the injectable facility. So it is a second choice of drug, and all professional body very, very strongly recommend that every woman who give birth must receive the active management of third stage of labor. Now, the carbetocin has come to our rescue around 1.5 years ago, and it is the thing for which we have waited along because it is a long-acting oxytocin, very, very strong affinity to oxytocin receptor, and it is a very good choice. And we have got the room-stable molecule or the carbetocin as well. Though I like to say that the carbetocin, even room-stable, is supposed to be stored around 30 degree, and when we have got the 40 or 42 degree temperature or more than 39, 40, then we have to be careful that it is stored in a good place. Champion trial after champion trial, carbetocin came into our country, and it is a very, very good effective drug as a MTSL, that is active management of third stage of labor, both in the cesarean delivery as well as the vaginal delivery. So it is a longer acting analog of oxytocin. So it also don't have any important contraindication. And what is very, very important, that it eliminates the requirement for infusion after initial dose, especially in women with preeclampsia, women with valvular heart disease, women with anemia. When we don't want to give the prolonged IV fluid along with the oxytocin because that has got the antidiuretic effect, the carbetocin is a preferred first-line drug for the active management of third stage of labor. Important thing that it should be, drugs should be available. So that is very important. We must be knowing many things, but that oxytocin, carbetocin, they must be available close to labor room, preferably in this refrigerator, and every skilled birth attendant, every nurse or every junior resident must know that it has to be given. So this is very, very important. The other arm is the late cord clamping, which has got benefit to baby, not for the mother. And the controlled contraction, the WHO and FIGO have got the bar that it to be done only when there is a experienced skilled birth attendant. So any new nurse or any new resident or house surgeon is not supposed to do the controlled contraction, because if it is done in a wrong way, it itself can cause the postpartum hemorrhage. So yet we have the all preventive measure, but it can be unpredictable in many situations, and we have to, what is the saying, more you sweat in peace, the less you bleed in war. So it is all about PPH drill and the all our system, that our drugs are ready, our instruments are ready. So why do mother lose life after PPH? Because we have a delay in correction of hypovolemia and delay in control of bleeding, maybe due to the like a suboptimal cause analysis. So this is very, very important, and it is golden hour, birth of gold and the diamond and sapphire, that these two are the aggressive resuscitation should be done, and you have to have a vigilant policy for the golden hour in our labor room system, that no woman should be shifted to the postnatal ward before the 2 hours, so that we don't lose the patient opportunity to treat into the golden hour period, and patient is shifted to ward, and suddenly we find the patient with the unstable vital. So we can have primary PPH, secondary PPH, we all know, but as a clinician, what we want, whenever you are being called to deal with the PPH case, first of all, take a quick 360-degree review, and a cause analysis is something very, very important, so that you pick up the right measurement for that particular patient. Tone tissue trauma thrombin are the standard cause, basic classical teaching what we have. Important thing is that how we do the cause analysis. We have to be very quick. If the patient was on oxytocin induction, she has the problem. she has the high parity, we will think of the atonic. But if it is a fibroid, there can be the fibroid related bleeding, or if it is a difficult delivery, large size baby, instrumental delivery, then the trauma will be there. And if there has been any difficulty in placenta removal, or it has not been expelled, then we have to look for the tissue and the abnormality of coagulation, especially when there is any precedent obstetrical situation which can cause coagulopathy, like preeclampsia, like IUFD, like abruptio, then we should always think that the coagulopathy can be the cause. So the cause analysis is very, very important, and there can be more than one cause. So if that is in PROM, it can cause infection, it can cause atony. We might have used the tocolytic, and again, when there is a preterm premature, there can be difficulty in expelling of the placenta, and the tissue also adds. So always consider there can be more than one cause. After this, the second thing is the diagnosis of PPH. So here is the time where the golden hour value is of immense importance, because the pregnant woman can have the stable vital unless she has lost a significant amount of the blood, because the pregnant woman is already hypervolemic, so she can withstand the PPH with the stable vital. And here are the thing why we have the pitfalls in the diagnosis of the PPH. Visible estimation throughout is, as a chairperson, Safe Motherhood Committee, Dr. Sheila Mane, we said always do this one desk, one workstation, that how do you estimate that this amount of blood is this. So we have to improve the skill of our all healthcare provider, that how they estimate the visible estimation of blood loss in a quite accurate way, and always give clear instruction to labor room staff. If the woman has soaked 5 soaked normal size pad in 1 to 2 hours, or a big napkin has been soaked, or there is a continuous trickle of blood, or you have certain measurement for the qualitative collection like the Devdas bag, and if the very, very important, that is altered woman condition. Patient is not bleeding, but she is having confused look, she is nauseous, she is vomiting. This is the time that we must think and then look for any postpartum hemorrhage. It may be concealed or the revealed. So once you have diagnosed with the visible estimation with all analysis, then we have to call the friend, because we need multiple hand to do multiple things. Whom to call has to be pre-decided. It is not to be walls or something unknown. Call them. We have to name whom to call and how quickly she or he has to be called. Anesthetists, senior nurse, our one obstetrician colleague, smartest ward by the eyes, theater staff to be notified that the patient is having PPH, might need shifting to operation theater, and the blood bank person. Now, how to do the quantification of the blood loss? So it is the cause analysis, and when we have these charts. Important thing that it should be in our hardcore system, it should be in our hardware. So it is not in in our all memory, that if it is pulse is rising, BP is less, tissue perfusion indicator are disturbed, less amount of urinary output, and we are not having a good capillary refill, then it shows that the patient is having moderate to severe postpartum hemorrhage. Shock index, very, very simple measure, that is heart rate by systolic blood pressure. And we can easily do if the woman is having the cardiac monitor in the labor room. If it is less than 1, we have a breathing space. But if it is more than 1, we have to be very, very aggressive in our measurement. Classical rule of 30, we know as a August over all viewers, but important thing is that all our nurses and junior resident must be aware of it and its implementation in day-to-day clinical practice. What we must have: all drug, oxygen cylinder, emergency tray for PPH, chart for PPH, and the contact number of all our friends which are needed. So the basic EMOC runs with the good fluid resuscitation, alerting, give antibiotic, record event, communicate, and we have to have a good cause analysis as well. So when there is a moderate to severe PPH, we have to be very aggressive in the resuscitation, monitoring, and arrest of the bleeding. And it is vital. It is again important. Something are non-technical issue which are very important. So any nurse calls you, the patient is not looking good, she is having PPH, you go into the midnight and say everything is fine, why you always call me? Second time she will be very afraid to call you. So this is very important, that never give this thing about something negative or loss of face. Always motivate them, it's good that you have called me. So few non-technical issues are as good. Now, when we have a moderate to severe PPH, we have to access airway, breathing, circulation, whatever is the oxygen saturation, the oxygen has to be administered, and always the 2 IV line, which is our lifeline, and it should be green and the gray. Keep the position woman flat, keep the woman warm, and if they give all catheterized bladder, and you have to send the blood for the cross matching as well as the investigation, and until blood is available, that is the another life-saving thing, that whatever amount of blood loss you are assessing, around 2.5 to 3 times fluid crystalloid has to be given. Manual aortic compression, especially in the situation like placenta accreta spectrum, when patients suddenly lose a large amount of blood, this technique has to be trained, and that everybody should be trained in it. You have to stand up, you have to be all what we do in the cardiopulmonary resuscitation, straight elbow and the thumb is outside, and you have to give that much of pressure that the femoral pulse is not visible, you are not palpable. So this is very important. It is a temporizing measure but can be the life-saving, and we have to send the blood sample at the same time. So in our PPH box, beside the drugs, beside the catheter and other things, we must have 3 plain vial, 3 citrated vial, and 3 EDTA vial, so that we can send the blood for the cross-matching, for the investigation, and for the coagulation profile. This is PPH bundle and the E-motive bundle, which are the set of the guidelines which are effective and which are always, they have been found with the consistency of the practice. And the uterotonic drug, crystalloid, tranexamic acid, and uterine massage is the first level of the care. So 8 to 10 liters of the oxygen per minute, crystalloid, crystalloid, crystalloid. So you have to give around 2.5 to 3 times crystalloid. And if the blood is not available, only then you will use the colloid in between, because colloids are not the fluid of the choice, because they remain into the intravascular volume, and that can cause more propensity to pulmonary edema, as well as they disturb with the coagulation function. Always Foley's catheterization and crystalloid, that is very important, that ringer, lactate, or normal saline are the fluid of choice, and it is around 3 times the estimated blood loss. So this I will emphasize: 2 IV line, green and gray cannula, ringer, lactate, or normal saline, and colloid. After that, if the blood component is not available and patient is having ongoing bleeding, then you can put the patient in between around for the hemaxin. So now, with this resuscitation, with this estimation of blood loss, then you have to ask again the question, few important questions: placenta is delivered or not, if it is complete or not. For this, you have to always instruct a protocol that placenta is not to be thrown away till 2 hours after delivery has been gone and the patient is well. If placenta not delivered, mobilize team for MRP. Placenta not complete, you have to explore the genital tract in a good setting. And if there is a suspicion of past disorder, like previous cesarean section, like previous any hysteroscopic surgery, or you think that the ultrasound findings are suggestive of it, never go for the placenta removal. So this is important. There is a gentle massage, how we do in the clockwise section, the removal of blood clot from the vagina, and this obstetrical art has to be retained with our teaching. So what are the oxytocin drugs? When you want to use in the this atonic postpartum hemorrhage, it is oxytocin, carbetocin, methyl ergometrin, misoprostol, and the PGF2 alpha. Important thing is 3 or 4 things are important. First of all, absolute search, look for any contraindication of the drug. Secondly, they should be available. Thirdly, they should be stored very well. And fourthly, they should be given in a good number. So it is not so that you give only methyl ergometrin, only one injection, or PGH carboprostodin, only one injection. So you can give around 8 doses of the prostodin, around 4 doses of the methyl ergometrin, and misoprostol 600 to 800 microgram. So this is very important because if we optimize the good use of the medical management of all the drugs, we can avoid the second line measure or the surgical exploration in majority of the patient. So these things are very, very important. And if you think that the oxytocin is not working, you go for the methyl ergometrin and PGF2 alpha, because the oxytocin receptor are different, and if one drug is not effective, then the second drug can be effective. So this is all we know. What are the drugs available about it? But important thing is the optimum storage, optimum availability, and optimum use is the most important, and always rule out the contraindication of that particular drug, especially methyl ergometrin not to be given in anemia, heart disease, preeclampsia, and prostaglandin not to be given in the patient with asthma and the bradycardia. Tranexamic acid after women trial has come to us for our rescue, and the EMOTIV and the WHO, Foxy, FIGO all recommend that the tranexamic acid to be given earliest. You can give prophylactically, and you can repeat within 3 hours of the recognition of the PPH. But after 3 hours, if you give, it is not going to be very effective drug, and it may cause harm as well. So all recommendations say that the tranexamic acid is an important drug to prevent the criticality and the severity of the PPH. Now, this slide is very important, and I want to warn that not only this is a paper from the Anesthetic Association, and very, very recent paper. In our National Medical Council also, it has been a matter of concern that tranexamic acid inadvertently has been given as a bupivacaine for giving regional anesthesia, and the patient loses life, or the patient had a lot of criticality. So both injections remain same, and this is a research paper which shows, and which is the experience of the NMC members, which have warned us that it is a very much reality. So keeping one magnifying glass in our operation theater is a very good option, and we can say as a professional organization that they can change the injection outlook as well. When you want to have the blood transfusion, if the moderate to severe PPH, hemoglobin is less, and for this, I will say, though we send the blood for investigation, but a quick HemoQ system should be always with us in the labor room, so that you give the hemoglobin. If it is 5, 6, you have to be very aggressive. If it is 9, 10, you have a breathing space. And in my clinical practice, I have found that this simple blood coagulation bedside test and the quick HemoQ system really gives you very much insight that how aggressive you should be. So whenever there is any precedent obstetrical complication which can cause coagulopathy like DSC, intrauterine fetal death, HELLP syndrome, severe preeclampsia, abruptio, you have to think for the fibrinogen. We talk a lot about the coagulation test and even the thromboelastography, but the thromboelastography is not very near around us because it is costing crores of rupees. It is only for a very, very difficult OT like ortho or the cardiac OT, but the bedside coagulation test stays with us. Within 10 to 15 minutes, they will tell you that the patient is having a good blood clotting, or that and this clot is stable or not. So these are the simple things which we have to retain in our teaching. Blood transfusion, again, one important thing that the massive transfusion protocol start after 3 to 4 units of the PRPC. So many times now the people say with the blood component right from the very beginning, it is 1:1:1. It is not so. For except leaving aside coagulopathy, in the other issue, always the blood component of the choice is the PRBC. And if the 2 or 3 unit has been given of the PRBC, patient is still having ongoing bleeding, then the massive transfusion protocol starts. What we want to achieve, good hemoglobin more than 8, platelet count more than 75 lakh, prothrombin time less than 1.5, and the fibrinogen more than 1. So we have to have the set the goal. always be available with all PPH tray, and we have the Manyata, which we are doing the training. Everybody's in South also. This is very strong program with the Foxy and with the Sheila Mane, with all the legacy of the Safe Motherhood Committee. We have always advocated that we must have all the instrument trays available for it. Always record parameters, event, what fluid has been given, and whatever the conditions are, we have to have a good communication with women attendants so that we have the cooperation. And this is about Manyata project, what we are having. And with the virtual technology, we are actually accessing to the paramedicals of the very, very small village. And that has really made a difference. Always treat the cause. If inversion, again, we will discuss into the case situation. Laceration has to be treated, and retained placenta, you have to remove the placenta. So with this, the second line measure comes. So it is a bimanual uterine compression, SR cannula. Dr. Samartha is going to say one important thing, that when the patient to be shifted to OT, we have to be very, very particular that we take right decision at right time. So good. If there is a laceration, you have to stitch well into that good setting. Dr. Pally is with us. He has invented a beautiful transvaginal uterine artery clamp so that you can put it transvaginally. It stops bleeding. It can sometimes cure bleeding, or it gives you good time to do the necessary measure. We have a good uterine balloon tympanode with us, and whenever there is a retained placenta, always mobilize early for the MRP, because the real difficult part about MRP is decision to undertake it. Always when there is a precedent, any condition which can cause coagulopathy, you have to pull him. So when it is time to open the PPH, this will be my last slide. Whenever there is a uterus flabby, Dr. Samartha, please mute yourself. So uterus flabby, lacks pouring blood. Dr. Samartha, kindly mute yourself. Yes, thank you very much. Uterus flabby, lacks pouring blood, unstable vital, indefinite contour of uterus. You are feeling lump or abdominally, or you are not able to suture the high cervical tear. This is the time that we must go for the opening up of the patient. And always the temporizing measure are the aortic compression, bimanual compression, and the non-pneumatic anti-short carbon. We have to have all the skill, which we are going to have good videos with Dr. Manju Pari and Dr. Samartha. So we have to save life, and in PPH, the roadmap should be clear. It is nothing very new what we are telling you. It is just we have to be naturally, our reflex should be set that what is to be done 1, 2, 3, 4, and we have to have a very good cause analysis and right decision at right time, and keeping good communication. So if you can fill the unforgiving minute with the 60-second worth of distance, run. And thank you very much for the patient listening. So leadership is commitment and conviction, and I present before you as a Foxy presidential candidate. And I sincerely request that everyone vote and support my candidature, because your vote will be the endorsing of the hard work and the commitment in our federation. And it will build the self-confidence in every OB-GYN across India, that the Foxy and our professional body believes in the hard and the consistent work. Thank you very much once again.
Hello. Hello.
Thank you.
Yeah, Prasanna madam.
Am I audible now?
Yes, madam.
Yes.
Thank you, Dr. Sadhana. It was very exhaustive and comprehensive, and you have given importance to the very, very minute points also. Very, very minute points, like the ambule of tranexamic acid mimics the ambule of buprenorphine, and so many things, and keeping the patient warm if she bleeds, and so many things. It is very, very exhaustive, and it's almost complete. I have a few comments, and you can anticipate, we have to anticipate postpartum hemorrhage in certain women, but it can occur in any woman. Even an young primate can bleed to death. So every delivering patient, we have to anticipate postpartum hemorrhage. As you have rightly shown the Manyata project, every delivering point should have a PPH box, and they should do PPH drills. Otherwise, when a situation comes, they won't be able to act accordingly. And this golden hour, Actually, there is no golden hour. If a patient can be exsanguinated to death within minutes, So it depends upon how fast he is bleeding. So if she bleeds so much, sometimes we see atonic PPH bleeding so profusely so that she can be exsanguinated to death within a few minutes. And we have found that the cannula, the suction cannula invented by Dr. Samartharam and Dr. Panikkar, both are good. And we have found it very, very useful in atonic PPH. But the thing is, we have to see what is the cause of bleeding. If she is bleeding from a suburethral tear or from multiple lacerations in the vagina or from cervical laceration, or it could be a ruptured uterus. So you have to find out the cause of bleeding, whether it is traumatic, and if it is traumatic, from where exactly she is bleeding. That's very, very important. So that is something which I wanted to stress. And actually, a woman who is delivering or even earlier, there is enough time for the woman to have her anemia corrected, and she should know what her blood group is. Her family should know what her blood group is, and then she has to find out a donor or more than one donor, same blood group. So correcting anemia in the antenatal period, educating patients, and teaching in the antenatal period is very, very important. And make sure she is not anemic when she delivers. And PPH box, I already stressed. When she is in coagulation failure, of course, we have to be correcting the coagulation failure and simultaneously managing the PPH. Don't wait for the coagulation failure to get corrected to manage the PPH. It can be, even if it is hysterectomy, you have to do the hysterectomy simultaneously correcting. If you wait for correcting the coagulation failure, you may lose the patient. And about suction cannula, Dr. Samartharam will be going to show the video, and it has actually revolutionized the atonic PPH. If it is placenta increta, it may not work. And placenta increta, we always go for cesarean. And I think all of us have adopted the management of going through a vertical incision, classical cesarean, delivering the baby, not disturbing the placenta, go for hysterectomy. And before hysterectomy, you have to gently dissect the bladder. You can devascularize the uterus by, if you are used to aortic clamp, you can use the aortic clamp, or you do bilateral internal iliac ligation. If you gently dissect the bladder down, you will not injure the bladder, and we can complete the hysterectomy fast. So these are the comments I wanted to make. And thank you, Dr. Sadhana. You are very exhaustive and very, very excellent in your presentation.
Thank you, Madam, for
and Dr. Sundara Meenakshi for chairing. Thank you to Dr. Sundara Meenakshi for pitching in at the last minute.
And it was a wonderful
Yes.
wonderful talk by Sadhana ma'am. But obstetric PPH is an obstetric catastrophe that not only kills the patient but also kills the obstetrician. Like what ma'am is doing, she is enhancing the skills of many junior obstetricians such that they become more brave to handle issues. We have missed our colleagues due to PPH death. Many of the obstetricians, they don't want to practice obstetrics. So ma'am is doing wonderful job. Ma'am, wish you all very success in your future, ma'am.
Thank you.
Yeah, Sahiti,
thank you, a very small request, Shalja. Dr. Samartha, Dr. Manjupuri is in the way. She has stopped in her relative's home, like after going to college. So if you permit that Dr. Manjupuri gives her
Samartha sir, is it okay with you?
Dr. Samartha, can I request? Because she is actually stopping in between.
Please tell me, are you able to hear me?
Yes. Dr. Manjupuri has requested because she is just in the way. Actually, she has stopped.
So she wants to present.
Yes.
Before
First.
me. No, please
Yes.
carry on.
Thank you very much. Dr. Manjupuri, you can
have Dr. Manjupuri madam's session. Yeah.
Thank you, Dr. Samartha.
Okay, fine. Thank you.
Yeah, selective devascularization in PPH by none other than Dr. Manjupuri, Director, Professor, and former HOD, Lady Hardinge Medical College, New Delhi. I'll be introducing the chairpersons for this session, Dr. Chandramati and Dr. Shanmugavadigal. Dr. Chandramati, CV, please. Dr. Pannam Chandramati is the Director, Sri Chandra Hospital, Karimnagar, Professor of OBGYN, Chalmeda Medical College, Karimnagar, and present Foxy President for this year, Karimnagar Society. She has been practicing for the past 18 years and has presented articles in many national journals, attended many international conferences, and has special interest in field of high risk obstetrics and infertility. Dr. Shanmugavadivu, CV, please. Yeah, Professor Dr. L. Shanmugavadivu is the Secretary of Obstetrics and Gynecological Society of Salem, Professor Department of OBG, Government Mohan Kumar Mangalam Medical College Hospital, Salem, with 16 years of appreciable service to our medical field and untiring teaching experience for both undergraduates and postgraduates. She has published indigenous articles in national and international journals with special interest in the field of high-risk obstetrics and endoscopy. I hand over the session to Dr. Shanmugavadivu and Dr. Chandramati.
Thank you, ma'am. Thank you for your kind introduction.
Thank you, Dr. Shailaja, for my introduction. I take the pleasure in reading the resume of Dr. Manju, Madam. Dr. Manju Puri, MD. She is the Director, Professor, and former HOD, Department of Obs and Gynec, LHMC, New Delhi. And she was a National Coordinator, Practical Obstetrics Committee, FOXY. And Madam is the President of National Association of Reproductive and Child Health of India, Delhi. And she's a member of Technical Expert Committee, DCGI, and a member of many technical expert groups of GOI, WHO, and UNICEF. And she is the External Quality Assessor for Public Health Facilities. She's a national mentor for the Lakshya implementation in medical colleges, and she has more than 150 publications and 1,600 citations. And she is the edited books like Anemia in Pregnancy, Management of High-Risk Pregnancy, A Practical Approach, and Clinical Methods in Obstetrics and Gynecology. And her field of interest is high-risk obstetrics, quality improvement, and reproductive endocrinology. So after a detailed and exhaustive talk about the medical management and resuscitation of in PPH by Sadhana Madam, we look forward to the this topic of selective devascularization in PPH by Dr. Manju Puri Madam. Welcome to the session, ma'am.
Thank you, Dr. Chandramati, and thanks to Dr. Smarth for having me, allowing me to make my presentation earlier. I'm actually traveling, so I am stopping in the middle. Yeah. So I'll share my screen. I hope my screen is visible.
Not yet, madam. Yeah, it's visible, madam.
All right. So it is indeed a great pleasure for me to be here and presenting. I'll be presenting, my talk would be focused on internal artery ligation. So we all know that bilateral internal artery ligation can effectively control bleeding and prevent need for hysterectomy. And in the previous session only, it was mentioned that this is one skill which all the obstetricians must have. And internal artery ligation actually controls bleeding by converting an arterial system into a venous system. It decreases the pulse pressure by 85% and blood flow by 48%, and then allows the clot to form. So that is how it would act. And if we look at the level of L4, and umbilicus is the surface landmark. So if you go at the level of umbilicus, just below it, you will find the bifurcation of aorta. Then the common iliac artery divides into external and internal iliac artery at the sacroiliac joint, anterior to the sacroiliac joint. So these points are important because when you are internal artery ligation, you must be familiar with surgical anatomy so that you can reach the right place. So we know that we can palpate the sacral promontory, we can palpate the sacroiliac joint, so you would know what structure is where. The next important point is that external vein lies medial to the external iliac artery and it lies lateral to the internal iliac artery. So this is another surgical point of surgical importance, because when we put a suture below the internal iliac artery, we always go from lateral to medial side so that the external iliac vein is not traumatized. The next point is that the internal iliac vein lies posterior and little medial to the external iliac artery. It is here. And then as you go down, the vein and the artery go away from each other. So we should try and go lower down and pass from the internal iliac. Another important point is that internal iliac artery divides the anterior and posterior 3 centimeters after leaving the common iliac artery. So that is why when we pass a mixture below the internal iliac artery, we always make sure that we are 3 to 4 centimeters below the bifurcation of the common iliac artery. Moreover, the posterior division leaves the internal iliac artery from its lateral surface. So it leaves it from the lateral surface. We normally don't see that, right? So we just go about 4 centimeters below, 3 to 4 centimeters. And once we pass the suture here, it means that the posterior division has been. Then the ureter crosses from the lateral to the medial side, and it crosses at the level of bifurcation. So this is how these are the points which are important from the surgical anatomy point of view. Now, I will just show you. There are 2 ways where you can approach the internal iliac artery, because we have to open the retroperitoneum to reach that. One is the anterior approach, or you can call it the lateral approach, and that is the posterior approach. So in the anterior approach, I'll show you this video here. Yeah. So you see that uterus has delivered out of the incision, and we have, this is the tube, this is the ovary, this is the round ligament. So we stretch the uterus onto the opposite side, and just behind the round ligament, somewhere either in the middle or more towards the lateral side, we hold the peritoneum with the help of an artery.
Dr. Manju, I think
Yeah.
yes, now it is available. In between, we lost this thing.
Okay,
You can
okay.
put your video up, I think, a little bit internet issue.
Okay,
Sometimes
I
voice is
will.
breaking.
Just
So that we can hear you well. Yes.
Just yes. Just a second. I put my video off, stop my video. Yeah. Is it, can you see it now? Sartha, can you see it now?
We can see. Video is,
Okay.
it is still, it is not.
I think.
I'm.
Madam, video is playing but slowly.
We can
Videos
see
are
the
not
image.
moving.
We can see the image, but it's not moving. Actually.
Okay, so let me just look up the net connection, maybe.
We can see the
Because
image,
it is-
madam, but the video is playing slow.
Shall I share it?
It's
Is it moving or it is not?
not moving, but shield people can
Not
you,
moving.
we can see the image, but not the. I think
I
you can
will share it.
explain.
Just-
Yes.
I will share it. Can you see it now? Is it moving?
It's not moving, madam. We can see the image.
Let's see connection. Sorry, just a second. Give me a moment. After just give me a moment, please. Sorry for the inconvenience here. After क्या hotspot कौन सा है? सही बाबा नेचर नहीं नहीं आपको कौन सा हॉट रेडमी है? करूं?
हाँ रेडमी है, रेडमी आया।
हाँ बताओ क्या है?
111 होगा,
1 8 times कितना 1 2 3 4 5 6 7 8
और ये टाइम्स क्योंकि बहुत ज्यादा यूज नहीं करते हैं।
आगे But device connected to I think it is more of a now. Is it visible now?
Image, I think Dr. Manju, you can tell, because we are seeing the image, so that you can explain it. Image is moving, but not the video.
Oh,
so you can explain it because we can see the image.
All right. It is just not moving, no movement at all, or it
No
is moving
movement.
slowly.
Slides are changing.
Ma'am, it's moving slowly, ma'am.
Achha. Oh. So shall I just try and explain it otherwise?
Yes.
Yeah. So basically, what happens, behind the round ligament, you open it vertically up. So once you open it vertically up, the first thing that you see underneath is the psoas muscle on the lateral side. And on the medial to the psoas muscle, you see the external iliac artery. So these are the two structures you would see, as you open the peritoneum. And when you open the peritoneum, you can always turn your two fingers and vertically dissect the loose areolar tissue. Right? And you get guided by the pulsations of the external iliac artery to know how deep you have to go. So once you are on the artery, you move your fingers down vertically, transversely, and you would palpate the external artery, and with the help of suction, you can see the external iliac artery medial to the psoas. And then medial to that, you will see the ureter crossing from the lateral to the medial side. Okay, with the medial flap of the peritoneum, you will see the ureter. So once you see the ureter, you can put two devers and retract them. Then deep inside, are you not able to see the video? I'm bad about it. The video is not seen. Hello.
Images are good. Images are we can see easily.
Just the image is moving, ma'am. We can't see the video.
Achha. Okay. I hope you read those markings.
Ma'am, your net connection is poor, ma'am. That's why it's coming like that. It's coming only in frame only. Movie frame, Madhuri, it is coming only in frames. You cannot see the complete motion picture.
But are you able to understand anything or nothing?
Yes. You can.
Yeah, we are able to understand, madam. You go ahead.
Okay. Okay. So, expose the internal iliac artery. That is the time when you put a mixture from the lateral to the medial side after removing the sheath of it. And if you dissect it lower down, then the sheath kind of disappears on its own, and you can pass the mixture from the lateral to the medial side, and then hold the thread and bring the thread out of it. This is the surface of the internal iliac artery. Once the sheath start, then be able to, it separates the artery. So it from the lateral to the medial side along the undersurface of the artery. You don't poke it deep, because if you poke it deep, then the vein might get injured. So this go and we would take it. So now this. All right, so I'll show you some picture in the posterior approach. I hope you can see it. Now, can you see the now? Are you able to see the slide?
Yes. Yes, madam.
This is the posterior approach. So here I'll be able to show you the stills. So here we did. So this is the posterior approach. So the uterus surface of the uterus, which we can see with the, and then we bring the uterus outside and retract it onto the opposite side. So this is the lateral pelvic wall you see. So this lateral pelvic wall, what you see, this is the uterosacral ligament. Can you see the uterosacral ligament? Can you see my cursor?
Yes,
Yes,
madam. We can see.
Can you see my?
Yes,
So
madam.
this is the uterosacral ligament. This is the posterior leaf of broad ligament. This is the infundibulopelvic ligament. If you see here, you can see the ureter crossing from the lateral to the medial side, and this is the external iliac artery. Are you able to see that?
yes, ma'am.
Then
Madam, we can
what
see.
we do is that, yeah, medial to the ureter, we'll have the
Yes, that.
peritoneum to an incision here, right?
Yes, ma'am.
And so the peritoneum is about 5 centimeter long on the peritoneum. So you have the ureter here, right? So with the help of my fingers, I am, putting 2 fingers and stretching the loose my finger so that I get by the pulsation of the external iliac artery. So after this, I reach the vessels, and with the help of a peanut, you can clear it further, and you can see that the medial end of the peritoneum, you have the ureter here. Can you see the ureter here along the medial leaf? If you see here, then we can see that this is the external iliac artery. This is the internal iliac. So we can see the external iliac artery, we can see the internal iliac artery, and this is the external iliac vein. Right? Which is clear. The next is we are going to put the lateral to the medial side so that we protect the external iliac vein. So it is from the side after I have dissected the fascia of the artery. So I pass the suture.
Now slides are not moving. Dr. Manju, now slides are not moving. Something really, internet issue is there.
Okay.
Yes, now the slide. I think you can go for the PPT so that you can. Yes. So now slides are moving. Yes.
Okay. So if you see here, I have passed it through. Can you see the suture being passed underneath the internal iliac artery? Right. So you have the external iliac artery, external iliac vein, and the internal iliac artery, and the ureter is the medial side of the peritoneum. So this is what we have tied, and this is how we close it. Right. So this is it. I have a video, but you can't see the video. I'm feeling so bad that I can't show you the video. Can you see the video or no? Shall I move to the last message?
Yes, yes, yes.
Oh, please, please.
So I think I'll just give you the last practical tips. So it could be that sound knowledge of anatomy is essential. We must open the peritoneum adequately for good exposure. So don't be miser in opening the peritoneum. So let it be widely open. Dissect through the loose areolar tissue with your fingers with linear strokes and not transversely. Use a suction cannula for dissection. It kind of keeps the field clear and takes care of the loose areolar tissue. Use deep retractors. Devers are very important to have. You must have deep devers. Identify psoas muscle. Start from the
Anju madam, we are not able to hear you. Hello?
The
Madam,
network.
not audible, ma'am.
Is a
Anju
network
madam, we are
problem.
not audible.
Internet issue actually. That's why.
Yes, yes.
Madam has to stop slide share actually before we go ahead. Shall I give her a call, madam?
Madam?
Yes, yes.
I
So
think
I think we can give like she has a very good video actually. She was very
yeah, madam.
clear.
She came for internal
very,
iliac artery ligation workshop to Vijayawada and showed it live on cadavers. It was beautifully shown, and we saw her videos also.
Her video were very clear, but
Yes,
somehow
madam.
because
Not
of
playing.
internet, because she is traveling now, that's why. So we can have comment from chairperson na, before we go to Samarthara.
Dr. Shanmugavadivu, your comments, please.
Actually, it would have been very useful. We have seen the video clearly. It was a nice talk by madam. You can ask her to post it in the group, ma'am, so that we can circulate it, this video.
Yeah, ma'am.
We can request her to post the video alone so that it will be useful for the audience.
Yes.
Before she has given the practical tips, even that audio was not clear.
Yeah, she shows it beautifully actually. Her video and her live demonstration is also very beautiful. I've seen it live also.
Okay, okay, ma'am.
We'll go ahead with the next session, Sadhana madam.
Go for the next session.
Please.
Sadhana madam, shall we go ahead with the next session?
For sure. Yes, yes, yes.
Yeah. Our next session is the video of SR cannula named after Dr. Samartharam, who is live here today to speak to us and demonstrate it to us. I introduce the two chairpersons, Dr. Radha and Dr. Nipin Cletus. Dr. Radha is the Secretary, Karimnagar branch of Foxy. She has done her MBBS from Jawaharlal Nehru Medical College, Wardha, and her MD from DY Patil Medical College, Mumbai. Advanced ultrasonography training under Dr. P.K. Shah, Mumbai, and done a fellowship in fertility from Oasis Infertility Hospital, Hyderabad, and in advanced laparoscopy under Dr. Neeraj Gupta, Hyderabad. She has worked for over 18 years in the field of obstetrics and gynecology as an assistant professor at Rajawadi Hospital, Mumbai. Currently working as the chief consultant at Science Hospital for Fertility and Laparoscopy, Karimnagar. She is a visiting consultant at Sunrise Hospital also. She has been a speaker at state conferences and national conferences. She is recognized for Dira Foxy Award in 2022 and Dr. APJ Abdul Kalam Health and Medical Excellence Award in 2023. Dr. Nirpin Cletus CV, please. He is from Adur, consultant obstetrician and gynecologist and gynec laparoscopy surgeon, Lifeline Hospital, Adur, Kerala. He has done her MBBS. His MBBS from Pushpagiri Institute of Medical Sciences, Tiruvalla, and MS from Government TD Medical College, Alappuzha, Kerala. He has presented papers in state conferences and bagged first prize for poster presentation twice in state conference. Has his publications to his credit in international journal, and his interest lies in minimal access surgery and high risk obstetrics. Welcome, Dr. Radha Kolluri and Dr. Nirpin Cletus. I hand over the second session to you.
Thank you, ma'am.
Dr. Radha, is she around?
Nipin is with us. Nipin is with us.
Yeah,
Dr. Nipin, yes.
Dr. Nirpin, please introduce Dr. Samartharam and go ahead.
Yeah, it's my pleasure to introduce Dr. H. Samartharam. He has been a pioneer in introducing the suction cannula to prevent PPH. And it is a privilege and an honor to share the same dais with him. He's the director and HOD of Obstetrics and Gynecology, Santarium Hospital, Palakkad, Kerala. And he has been the winner of the prestigious senior category Foxy Corion Award, 3 times winner of Dr. C.S. Don Prize, Foxy Figo Award, KFOG President Gold Medal, and his PPH suction cannula, as we all know, and oral hydration therapy to prevent severe preeclampsia could bring down MMR very significantly in Kerala, Tamil Nadu, and AP. And he has got several publications, and his special interests lie in PPH, preeclampsia, amniotic fluid, optical density, and guided induction of labor. Welcome, sir, to the session.
Thank you very much, Nirpan, for giving me this nice introduction. Good evening. Good evening, everybody. I'm very much thankful to Dr. Sadhana Madam for giving me this opportunity. Screen this share screen. I'm with her since very long time. With every session I'm there. She made me go throughout India, northeast, north, south. Now we have come to south, and today I'm here to give deliberations at this new innovation and SRPP suction cannula. Most of us, all of the people, all of the obstetricians in India knows about this. And 1 minute. Just. I think my voice is audible, I think, no?
Yes, sir. Audible.
Yes. The title of the topic I'm presenting, SRPP suction cannula for the management of atonic postpartum hemorrhage. Postpartum hemorrhage is the leading cause of maternal deaths all over the world, amounting to 28%. Around 50% of the mothers die due to atonic postpartum hemorrhage. Millennium Development Goal 5 aims for reducing MMR to 70 per 1 lakh births by the year 2030. Now itself, most of the southern states have achieved this 70 maternal deaths per 1 lakh births in South India. When conservative methods like uterine massage and uterotonic drugs and balloon tamponade fail, surgical interventions which need laparotomy are needed to stop bleeding. In low resource settings, it is difficult to organize competent manpower, compatible blood, and transport to higher medical centers. Get me some water. Many times mothers die on roads while being transported to higher medical centers. I think my voice is very clear now.
Yes, sir, it is clear.
This is the SRPP suction cannula which I have developed, measures 23 centimeters long, fundal portion having larger round holes. This cervical portion is having round small holes, and this the vaginal portion do not have any holes. Is a nipple of the cannula which stays outside and to be connected to the suction machine through tubing like this. Coming to the mechanism, how it works. This is the atonic flabby uterus bleeding cannula inserted here. When negative pressure applied, the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherent. Uterus becomes a closed cavity. Further continuation of negative pressure results in constriction, contraction, firm retraction of uterus on the surface of the cannula, which assists the physiological process of contraction and retraction to stop atonic bleeding. This uterus I'm showing here, inside this uterus, there's a cannula working and creating powerful negative pressure. And you can see it's not rugosities, coarse ridges on the entire surface of the uterus, both upper and lower segment. It is the global powerful constriction of the uterus which make the uterus contract and retract. Because of this global constriction, this cannula is very effective to stop bleeding, even in case of lower segment bleeding in case of placenta previa. If somebody is saying that this cannula do not work for lower segment bleeding is not correct, you coolly ignore it. Achieving closed uterine cavity is a basic and fundamental requirement for the functioning of suction tamponade system. Different obstetric bleeding situations have different cervical dilatations and different uterocervical lengths. It is not possible to achieve closed uterine cavity with a single design of a cannula. This is a post-abortal uterus with a short uterocervical canal length, and cervix only admits one finger. You have to select a thin cannula. This is the postpartum uterus with about 8 to 10 centimeter dilatation. You have to select a larger diameter cannula. If you use a thin cannula, immediate postpartum uterus, the cervix cannot grip the cannula properly, and it is difficult to form a closed uterine cavity, and this do not work well to stop bleeding. Different sizes of cannulas are made to match different cervical dilatations and different uterocervical lengths. These are the cannulas designed for atonic PPH after vaginal delivery. This is the APU and lateral view, and these are the cannulas designed for atonic PPH during cesarean section. This is the thin cannula meant for cervix admitting one finger, and this is the larger diameter cannula meant for dilated cervix. This is a special cannula designed for bleeding after MTP or vesicular molar extraction, and this cannula is also used as a suction tube introducer while doing cesarean section. And when you compare the balloon tamponade system with SR cannula, the mechanism is totally opposite here with balloon tamponade. Here the water-filled balloon dilates the uterine cavity, and the distended balloon compresses the bleeding sinusoids to stop bleeding. Whereas vacuum tamponade system assists the natural physiological process of contraction and retraction to stop atonic bleeding. SR cannula application for atonic PPH during vaginal delivery. I'm showing a small video here. Please go through.
Woman bleeding profusely. Vagina retracted with white blood speculum like this. 5 centimeters of anterior cervix is caught with the sponge holding forceps like this. Cannula inserted. Tip of the cannula should be at the level of fundus and should be fed bimanually. Nipple of the cannula should be connected to the suction machine through tubing. negative pressure should be applied. A negative pressure of 650 millimeters mercury should be applied for 10 to 15 minutes. You can see complete cessation of bleeding within 4 minutes. Retracted well.
Application of negative pressure. A negative pressure of 650 millimeters mercury should be created and maintained for 10 to 15 minutes, and then the machine should be put off. This procedure should be repeated every hour for 3 hours. After 3 hours, the cannula should be kept in the same position without removal and should watch for bleeding. In case of recurrence of bleeding, negative pressure should be applied by just switching on the machine. How long to keep the cannula inside the uterus? This is a common question everybody asks. Usually, the cannula can be removed after 6 to 8 hours. In case of high-risk woman, cannula can be kept inside the uterus as long as the bleeding expected, even up to 24 hours. Whenever there's a recurrence of bleeding, just we can switch on the machine and we can stop the bleeding. SR cannula application for atonic PPH during cesarean section.
Cannula system should be organized while setting the trolley itself. The intended cannula for application should be fixed to one side of the suction tube. Other end of the suction tube As this is an elective section, I am dilating the cervix with index finger. I use thin long cannula, which I call it as a number 5 cannula, as a suction tube introducer. Suction tube should be connected to the suction machine. Cannula should be kept in proper position like this. Cut edges should be kept close together. Mop pressure applied. Negative pressure applied. You can see complete cessation of bleeding, contracted and well retracted uterus. You can see practically no bleeding. I am closing the left angle under direct vision. Contracted and retracted uterus. Blood loss less than 100 ml.
One information I would like to give you here is before you applying negative pressure, you need not close the uterus. You just keep the cut edges together and apply some pack on that and seal it and just apply negative pressure. The cut edges themselves come close together just like a valvular mechanism and create a closed uterine cavity and start working. After application of negative pressure, you have to wait for a 1 minute time without disturbing anything. The entire uterus squeezes and all the blood will enter into the blood from the uterus, enter into the circulation. You can see a blanching effect and completely uterus will get contracted, retracted like a cricket ball. Prophylactic application of SR cannula is done for women who are at high risk for developing atonic PPH like PIH, anemia complicating pregnancy, and accidental hemorrhage.
For prophylactic application, we have to check the suction machine before the delivery itself for proper functioning. And we have to organize the cannula system. Cannula should be firmly fixed to the one end of the suction tube. Other end of the suction tube should be firmly fixed to the suction machine like this. After the delivery of the baby and before the delivery of the placenta, vagina retracted with white blood speculum. Mild traction on the umbilical cord. 5 centimeters of anterior cervix caught with the sponge holding forceps like this. After the delivery of the placenta, without wasting any time, left 2 fingers inserted deep into the cervix, cannula inserted into the uterine cavity, taking the guidance of left fingers, tip of the cannula at the level of fundus, negative pressure applied. You can see complete cessation of bleeding. Total blood loss is around 50 ml. Uterus retracted well. SR cannula for traumatic PPH. I suggest to apply SR cannula for every case of PPH, whether it is traumatic or atonic. In case of advanced traumatic PPH, some amount of uterine atoning is always possible. If you apply cannula, the atonic component of the uterus will be corrected by the suction of the cannula and bleeding stops from the uterine cavity. And if you apply mild traction on the suction tube, the entire n-mass uterus will descend down, and there's no need to apply sponge holders to explore the cervix. If you apply traction on the suction tube, entire mass of cervix, uterus, everything come down. You can apply a speculum, visualize the tears of the cervix and tears in the upper vagina and suture them very nicely. Because blood is not coming from above down from the uterus, the field is totally bloodless. It will be very comfortable for suturing. SR cannula is very effective for transporting the woman to the higher medical centers. Here we use this manual suction pump. Manual suction pump can also be used to create negative pressure inside the uterine cavity. This is useful in places where there is no power and also helps to transport the patient with in situ cannula. Then the question is how to remove SR cannula after the procedure. After the completion of the procedure, the cannula cannot be removed easily as the soft cervical tissues get sucked into the perforations of cervical portion of the cannula and become adherents. Cannula can be removed easily. Cannula can be easily removed after gentle separation of these adhesions with finger manipulation like this. This cesarean section I did last night. Next morning I am removing this cannula.
Are you able to see now?
You have to insert the finger in between cervix and the cannula, go on sweeping and go on releasing the adhesions, the tissue stuck in the holes of the cannula, cervical portion of the cannula. Once you detach these adhesions, the cannula will come out easily like this. How to clean the cannula? Some people are asking questions like this. I just made a small video for this. To clean the cannula, immerse the cannula inside water. Kink the suction tube and put on suction machine and create high negative pressure inside the suction bottle. Then release the kink. By gush of entry of water inside the cannula get cleaned. Then the question, somebody was asking whether cannula can produce inversion of uterus. Inversion of uterus cannot, SR cannula do not produce inversion of uterus, but inversion of uterus can be treated with SR cannula. You can repush the uterus back into the abdomen, you can insert cannula and then apply negative pressure. Immediately the uterus gets freeze in that position and prevents recurrence of inversion. Cannula is also very effective to stop uterine bleeding, even in case of coagulation failure. There's a case of cupular uterus with coagulation dysfunction. We have used SR cannula here, and you can see complete contraction and retraction of uterus. We could save the mother and we could save her fertility function. Further, if there's a difficulty, you can call me to this number. I have given this my number here. I can come to your help. Under care of Government of Andhra Pradesh, SR cannula and oral hydration therapy to prevent severe preeclampsia and eclampsia were introduced in Chittoor district of Andhra Pradesh. Again, this oral hydration therapy to prevent preeclampsia is my own original work. I'll share it now. Oral hydration therapy is nothing but making every antenatal mother to consume more than 3 liters of water after 24 weeks of gestation to prevent severe preeclampsia and eclampsia. Hands-on training workshop was conducted at District Hospital Chittoor. Suction cannulas are provided to all institutions conducting deliveries like PHC, CHC, area hospitals, and all medical colleges in the entire district. ANMs and ASHA workers were assigned the job of OHT to all antenatal mothers to prevent preeclampsia.
In peripheral centers with suboptimal facilities, we advise the prophylactic application of SR cannula to all women, both in case of vaginal deliveries and cesarean sections. I would like to show the results after 3 months. We made a review. 8,000 in the entire district, 8,400 deliveries took place. Around 1,500 applications of SR cannula has taken place, included both cesarean and normal deliveries. Cesarean sections, 429 applications took place. And you see the total number of blood transfusions, only 28. For 8,400 deliveries, only 28 units of blood transfusions were done. Here they have used SR cannula for every case in peripheral centers. If you go to the comments of the doctors who have given, control is good, useful in arresting PPH. Like this, we can see wonderful comments from the doctors. This has been recorded in the district medical officer's office in the records. 5 years performance of SR cannula and OHT in the entire Chittoor district. I got recently this record from the district medical officer. You can see here the 47 maternal deaths were there between 17 and 18, whereas 20 to 23, 47 deaths has come down to 9 deaths. Hemorrhagic deaths were 9 in 17, 18. This has come down to 0 for full 1 year. 30,000 deliveries, there's not a single maternal death due to PPH. That's a great achievement of SR cannula in Chittoor districts. Then coming to the PIH deaths, 16 maternal deaths were there. 16 maternal deaths during 17, 18. They have come down to 1 maternal death this year, that is 22, 23. For 30,000 deliveries, only 1 maternal death occurred due to PIH. You can see the MMR from 83 during 17-18, it has dropped to 33.5. There's such a drastic reduction of MMR in the district. This significant reduction in MMR is due to the combined effect of SR cannula and OHT. Now, entire Tamil Nadu, Kerala, over 80% of Andhra Pradesh and many major hospitals in Karnataka are using SR cannula to prevent and treat PPH. Kerala Federation had included this device in its obstetric protocols to prevent and treat PPH. If you go to the statistics of South India, you can see a drastic reduction in MMR in Andhra Pradesh, Telangana, Karnataka. Kerala, it has dropped 36% drop in the maternal deaths. The Kerala MMR today is a 19, which was never before. This is only because of SR cannula, and many people are using OHT also to bring down maternal deaths due to preeclampsia. SR-PPH suction cannula is a breakthrough innovation to prevent and treat atonic PPH. This is a simple, cost-effective, life-saving and fertility-saving technique. This is a simple method, does not depend on biological factors for its action. No need to maintain cold chain. For the same reason, it doesn't fail. Suction cannula system can be organized within 2 minutes time. Bleeding stops just within 2 to 3 minutes. Cannula system works well even in case of coagulation failure. Even staff nurses can be trained and the bleeding can be stopped without any delay. Highly cost-effective, autoclavable and reusable instrument. Helps to reduce maternal mortality due to atonic PPH in low resource settings. One take-home message I'm giving to all the listeners and the faculty here. Most of the times, cannulas are purchased, but they are kept in a shelf. They are not using it. They exhaust all the techniques available, blood transfusion. Ultimately, at the fag end of this, they are putting the cannula and bleeding is stopping and mother is being saved. What my suggestion is, don't wait such a long time. The moment you see excess blood, you don't even wait for PPH, the amount of blood loss more than 300, 500 ml. You just you are feeling that it's excess of bleeding, just insert cannula and put on negative pressure. You can avoid blood transfusion, you can avoid transport, you can avoid tension, you can prevent maternal death. Thank you very much.
Dr.
Thank you,
Nathan,
sir,
your
for
comments,
that.
please.
Yeah, thank you, sir, for that wonderful and very precise, interesting presentation. You deserve all the accolades which are coming your way for your revolutionary work in preventing PPH, your cannula in a very big way. And I'm very happy that the other states are taking it up too. And let's hope that it percolates throughout the lengths and breadths of India. And Let's bring down the maternal mortality rate, which is a cause we are all working for tirelessly. It was a wonderful presentation, sir. Thank you so much. It's a privilege for me to chair for you in such a session. Thank you.
Thank you very much, Nirpan. You're from Addur, I know.
Dr. Samatharam, we have questions. How can we get this SR Canada?
My number is there. My number is there everywhere now. You can, because everybody knows my number. I am only manufacturing. I am only marketing. It's not available anywhere. You can just send a message, WhatsApp message to me. I'll send them. Any number, anybody, any people can get it very easily.
So post your number in this group so that people can have it to contact you.
Yes, I'll post a number.
Dr. Charu Jandial is saying wonderful presentation. SR Canada appears to play an important role in controlling PPH. But what effect does it have on endometrium and future fertility, since 650 millimeters of mercury pressure for 10 to 15 minutes is quite a lot for endometrium to sustain?
It's not like that. Immediately during after delivery, thickness of endometrium is very thick. In the postpartum period, all this endometrium will get necrosed and get shed off. And we have been lakhs of applications of SR can have taken place in the South India, all over India. No such either infection nor endometrial problems are observed. It is very safe. And another thing, 650 millimeters of mercury we have to do because it's a matter of bleeding, life-threatening bleeding. We have to stop bleeding as quickly as possible. That's why we have fixed this 650. Another JDA system, they have put 60 to 80 millimeters of mercury. This JDA system is from US, and it will take long time to stop bleeding. If I have observed here 60 and 80 millimeters negative pressure, it even won't stop bleeding. Most of our Indian machines are there must be some leaks are there. When leaks are there, 80-90 millimeters mercury blood pressure, negative pressure, it cannot stop the bleeding. That's the reason we have to keep. That's a very short time we are putting, 10 to 15 minutes only. Whereas JDA system, they want 80 millimeter mercury for 1 hour. That's not necessary.
Sir, I have a doubt. Sir, have you ever heard about any perforation done anywhere with SR cannula, sir?
No, it is not possible rather, because that's why it is not a small tube like Panikar cannula. Panikar is something different. I don't want to speak here on this platform. And see, it has specially made this size of the cannula is about 18-20 millimeters. And the tip of the cannula is cone. And it is such a blunt thing. And the fundus of the uterus is very thick after contraction and retraction. It is not possible to perforate fundus with this such a thick cannula. That's the reason fundus perforation we have never seen, we have never heard, we have never seen. It's unlikely, it's impossible rather.
Great, sir.
You can ask me anything, I'm ready to answer you. It's my pleasure.
Thank you, Dr. Samatharam, for that lucid presentation, live demonstration with videos and answering the queries. We would go ahead with the panel discussion. Welcome to our expert panelists, Dr. Bharti Rajshekar, and our moderators, Dr. Jyotsna Suri and Dr. Shiba Marwa. Dr. Bharti Rajshekar, CV, please. Dr. Bharti Rajshekar is the Medical Director and OBGYN Consultant, Vatsalya Hospital, Hassan, and Sahyadri Hospital, Honorary Secretary General, KSOGA 2021-2023, and KPMEA State Vice President and Director of Indian Red Cross, Hassan. She has many awards and activities to her credit. She has been the FOXI Public Awareness Committee South Zone Coordinator and Preventive Oncology Committee member. She has been a member FOXI Food, Medical Equipment and Drugs Committee. She is a trainer for FOXI Veera programs and FOXI RAC programs. Welcome, Dr. Bharti Rajshekar, madam.
Thank you. Thank you.
Dr. Jyotsna Suri is HOD Department of Obstetrics and Gynecology, Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi. And Dr. Shiba Marwa is Associate Professor, Department of Obstetrics and Gynecology, BMMC and Safdarjung Hospital, New Delhi. She was with us in Vijayawada as the Yuva speaker in our Yuva Swadhyaya in 2022 and an excellent orator. Welcome Shiba Marwa madam. I hand over the session to Dr. Jyotsna Suri and Dr. Shiba Marwa. Dr. Shiba Marwa, will you please introduce our panelists? And panelists, please put on your videos and rename your screens with your name.
Yes, thank you, ma'am. So our first panelist is Dr. K. Sundara Meenakshi. Ma'am is an MBBS from Government Stanley Medical College and MS Obs Gynae from Sri Ramachandra Medical College Research Institute. She is a gold medalist and has been bestowed with Best Outgoing Postgraduate in the year 2003. She has presented various papers in ASUG and Yuva Foxy. She's trained in colposcopy and tubal microsurgery. She worked as an assistant professor in Salem Government Medical College and Hospital, but currently she is consultant in Sri Meenakshi Women Care Clinic, Priam Specialty Hospitals. Her field of interest is obstetric and fertility medicine. Our second panelist is Professor S. Dilshad. Ma'am is consultant at Crescent Hospital, Madurai, and she's a professor and head of the department, Kalasalingam Medical College and Hospital as well. She was former director Institute of Social Ethics, Kasturba Gandhi Hospital. Currently, she is an executive member of Madurai Obs Society. Our next panelist is Dr. S. Nilofer. She's a consultant at Crescent Hospital as well at Madurai. She has done her graduation from Madurai Medical College and post-graduation from Kasturba Medical College, Manipal. Her field of interest is infertility and high-risk pregnancy. She's trained in basic ultrasound, hysteroscopy, and ultrasounds from female in India. Welcome you, ma'am. Next panelist is Dr. Bhavya GS. She is consultant obstetrician and gynecologist at Lifeline Hospital, Adur, Kerala. And our last panelist is Dr. Jesna Hassan. She is a consultant obstetrician and gynecologist at Lifeline Hospital, Adur, Kerala.
Dr. Bhavya, please rename your screen with your name. Dr. Shiva, you are sharing your screen?
Yes, ma'am. I'm sharing. So are my slides visible, ma'am?
Yes, they are visible. You can make them full screen. Yeah. Thank you, Shiba. So good evening to all the respected delegates who are here with us today evening. And we are going to be doing a very important panel. So we are very lucky to have such an esteemed panel with us who are all experts in their field and can share their experience with us today evening. So we will be discussing three important cases which are not commonly seen as routine atonic PPH. So Dr. Sadhana wanted us to discuss cases which are little different from the normal atonic PPH. So we have chosen cases which have been managed in our hospital. So to begin with, even though PPH is now something which is so much under control, but it is still seen very often. And this slide we put to show that in our obstetric critical care unit, 6% of all the admissions were due to PPH. So it is not as if that even in a tertiary medical college, we do encounter PPH very often, severe enough to reach the critical care unit. So if you see in the country, it is still the leading cause of maternal mortality. And therefore, even though there are risk factors for PPH, but many times it strikes without any risk factors. So we all have to be prepared with regular drills for our residents and our juniors who manage PPH, because when it occurs, it can lead to very severe consequences. Yes, Shiva, next slide, please. So the PPH definition, we all know. The classic definition is that it is a blood loss more than 500 ml after vaginal delivery or 1000 ml after cesarean section. But that being said, this definition doesn't suit
our country because many of our women are very anemic, and even a blood loss of 200 ml or 300 ml may lead to hemodynamic changes in them, tachycardia, they may start having hypotension. So it is not just the amount of blood loss, it lot depends on their weight, on their origin, what is their baseline hemoglobin, and also what is their, whether they are pre-eclamptic women. So those who are pre-eclamptic, they do not have a hypervolemia of pregnancy and they cannot tolerate blood loss, which, a normal pregnant woman can withstand. So many factors are there, and therefore we welcome the definition which says that any hemodynamic instability, which even whether it is less than 500 ml in vaginal delivery or 1000 ml in cesarean, should be treated as a PPH. And what Dr. Samarth was saying just now, we should not be waiting, for patient to become unstable. So the minute we think that this patient is bleeding little more than normal, or her pulse has become fast, or her shock index is approaching 1, so we don't wait, for the patient to deteriorate. We should start our action immediately. So when we classify, these are the traditional, again, RCOG has defined as minor and major, and amongst major, the moderate and severe. And one thing again, as I was telling you, you can see that blood volume is dependent on the weight. So a 60 kg woman has a 6 liter of blood volume at term, and she can withstand 2.4 liter of blood loss, that is 40%, before there is a life-threatening event. But a woman who is 40 kg will not be able to withstand that much of blood loss. So a lot depends on what is the weight. So yes, Shiva, please move on. So we know the causes, and we will be delving upon some of the important causes besides the tone. We are going to be talking of the trauma and of the tissue when we discuss today's cases, and the thrombin also. So the other 3 T's we will be discussing in our 3 cases. And again, this slide is there to show us that, like, there are so many conditions which we recognize as, golden first hour of resuscitation. And for instance, if there is a stroke, or there is a MI, or there is a trauma, so in all those, there is a golden hour. And in PPH also, the golden first hour is the one in which we have to save the woman, because otherwise there can be very serious impact. And if we don't treat, this grave consequence that she may even lose her life. Okay, next please. Yes. So now to walk towards the road to safety, we will be now, discussing some cases. So Dr. Shiba will discuss these cases, and we would really welcome all our panelists to give any input besides what will be asked from them, but they can also give their other inputs if they have something to share. So thank you so much. Shiba, please start with the cases.
Yes, thank you, ma'am. So, starting with the first case, she was a 22-year-old primary gravida at 35 weeks period of gestation who came to substance casualty with complaints of yellow discoloration of eyes and urine since last 3 to 4 days, vomiting since 3 days, and labor pain since 4 hours. On examination, she had tachycardia, pulse was 92, her blood pressure was 130/90, her respiratory rate was 26 per minute, she was afebrile, her saturation was 96% maintained on room air. On per abdominal examination, uterus was term size, irritable, cephalic presentation, fetal heart was 120 beats per minute and regular. On a per vaginal examination, os was 3 centimeter dilated, 50% phase, station was at -2 vertex, and membranes were present. So we admitted her and sent her routine investigation. So her hemoglobin was 8.4, her TLC was 17,700, platelets were 1.5 lakh per millimeters. Her LFT came out to be total bill about 12.6 milligram per deciliter as was expected. Her OTPT was 544 and 344. Her KFT urea was normal, but creatinine was raised to around 1.7 milligram per deciliter. Her blood sugar was decreased to 67 milligram per deciliter. Her coagulation was also decreased. movement time being 52 seconds, and INR being 2.7. Though her viral markers all came negative, an ultrasound third trimester was also done, which was suggestive of a live fetus corresponding to 34 weeks with a BPD of 34 plus 2 weeks, and Liker was adequate. However, placenta was upper posterior. There was mild ascites, which was mentioned, and bright liver was a report which was significantly given in the ultrasound. And also there was right pleural effusion. So my first question goes to Dr. K. Sundara Meenakshi. What is the provisional diagnosis, ma'am, and what are your concerns for this patient?
Ma'am, from the history, she is a primigravida with vomiting for 3 days and pain abdomen for 4 hours and with an irritable uterus. Now with the investigation reports, hemoglobin is 8 and her LFT is bilirubin is 12.6 and her liver functions are deranged and even her creatinine levels are high. Most probably my provisional diagnosis for this case is HELP syndrome because the BP was also 130/90 at the time of admission.
Anything else, ma'am? Because her bill is raised, OTPT is raised, but her platelets is pretty normal. Her DIs, coagulation is also deranged, and her blood sugar is low.
Severely deranged, ma'am. Mostly it is a HELP syndrome only, ma'am. My provisional diagnosis is a HELP syndrome, and it is pretty well known that I am concerned for this patient because it is a daring obstetric emergency because her INR is so much altered and she is getting into labor. So I have to, I feel like I should initiate an emergency response in the labor ward, keep my emergency team alert, and I have to inform the patient's attenders first thing that this patient is a critically ill patient because everyone will think, okay, she is in labor with vomiting. I definitely want to inform the attenders she is a case of dangerously ill patient because this is the patient who is going to pull me down. She can go in for a major obstetric catastrophe. Mostly severe form of PPH she's going to land up with.
Yeah, thank you. I think I see our expert's hand is raised. So, and also I wish to welcome our expert, Dr. Bharti. Thank you, madam, so much to be here today evening to share your experiences. So, yes, I think you want to add something to this.
Yes, I would go with this. I would, one is HELP syndrome. I think the second is acute fatty liver of pregnancy. Though very rare in pregnancy, we always have to keep our minds open because our serum bilirubin is almost 12, which usually in HELP syndrome, we do not have that levels of bilirubin. So I would go with the diagnosis of acute fatty liver of pregnancy.
Yes, ma'am. I think you have given a very good input about this. And one more thing which we would like to add is that in HELP syndrome, normally the coagulopathy is not a very striking feature. It is seen very rarely, even though the platelets are low, but we may not get a deranged INR. So any condition in which there is jaundice like a bilirubin of 12, as madam has mentioned, and in which the INR is deranged, like we see here 2.7. So we should be alerted that it is a AFLP, which though not very common, but it is still seen, at least in the tertiary referral centers, we see it quite often. So yes, Dr. Shiba, please continue.
So ma'am, the concerns for this patient were like this patient was a 22-year-old primary gravida, 35 weeks of gestation, as ma'am rightly pointed out. She was with AFLP, with hypertensive disorder, with multi-organ failure in early labor. So the concerns would be that she would be an increased risk of PPH as she was already anemic with HB being 8.98 and patient was already going into active stage of labor and she has deranged coagulation. And we would also dread the complications which are related to AFLP in pregnancy, which are the hypoglycemia, DIC, which both patients have already had. She might go into hepatic failure, hepatic encephalopathy, pulmonary edema, sepsis, and MODS. So the labor progressed in this patient spontaneously and she delivered a term live male child of 2.5 kg by normal vaginal delivery with right middle-lateral episiotomy. Active management of third stage of labor was done and patient had a tonic PPH with blood loss of around 800 cc. So blood loss, as we know, there is visual assessment and clinical signs, and assessment visual is always less than actual blood loss. So we must always take it with a pinch of salt. And then there are new methods which are available for estimation of blood loss in PPH, is already highlighted in the earlier presentation, where Brassfield rates and Kelly's pad are also come into play. And grading of blood loss, as Josna ma'am had already highlighted, when a patient has lost more than 40% of blood, so that means almost whole of the volume is 3 times the blood volume has already been lost. So she has to be replaced. And that is the critical stage. That is the class 4 of grading of blood loss. And clinical assessment should always be taken into picture rather than just the visual assessment, because that is lower. So my question for Dr. Dilshat is, what should be the immediate management in this patient now? And what is the bundle approach of FIBO and how does it help? Dr. Dilshat.
So here is the patient where we have to concentrate on 2 things. One, she's having already anemic and she's having disturbed coagulation profile. And third one, apart from this, she's having atonicity. So all the things to be concentrated on this. First, what we have to do is we have to call the emergency response team for help once the uterus has become. Now, what are the things to be done? The steps are taken to resuscitate the patient, to monitor the vitals, arrest the bleeding, and of course, we have to do concentrate all those things. Here, when coming to the general measures, apart from all these things, this emotive, what we are going to do is, we have to massage the uterus and administer oxytocin and tranexamic acid, and crystalloids to be started immediately, but still the patient is already anemic, already lost amount of blood. So I would suggest the patient can go with components of the blood, and again she is having a prolonged coagulation time. So what we have to do, that 1:1 ratio of pap cell, platelet, and FFP to be given, because in such patients, this is the thing also to be replaced. And coming to this massage, where we are going to have bundle approach in this first response treatment bundle for PPH comprises of massage, oxytocin, but everyone knows the oxytocin, what we are going to give is oxytocin 20 to 40 units given in 1 liter of crystalloids. It is given rapidly, 500 ml in half an hour, and that is followed by 250 ml every hour. And again, we are going to give methyl ergometrin where there is no contraindication, 0.2 milligram intravenously, very much slowly. Most of the time, the uterus contracts with 2 oxytocin. If necessary, we can go with prostaglandin F2 alpha, 250 microgram intramuscularly, even you can give intramyometrially. And of course, the other things which are available are misoprostol, 800 to 1000 microgram in rectally, or 600 to 800 sublingually or orally. Carbetocin, of course, everyone knows the coming up drug, which is being very much encouraged by everyone. So this is regarding the oxytocin. Then IV, where the crystalloids, meantime, we have to make arrangements to give 1:1 ratio of all the blood components. And meantime, we have to examine the patient rapidly. Is there anything else is present? And we have to empty the blood and look for the urine output. And is there any bits which are being retained below? So all these things are being taken, and we are going to monitor the patient. If the patient is not responding to all these things, we have to go with the refractory treatment bundle for PPH, which comprises of balloon tamponade and anti-shock garment, which maintains the pulse and BP, so that we have to plan for further things. Madam, I would like to say that when I was a HOD, Professor Government Rajaji Hospital at Madurai, I have presented a paper at ACOG Benares, where I have 274 cases of jaundice has been studied in this project. Where what I have observed, when I was a postgraduate, most of the time the patient dies of bleeding. But now, once we replace FFP and keep it there, and most of the time the bleeding is not much. Of course, here we are talking about atonic PPH, and most of the time these patients on the 2nd or the 4th day, whatever be the treatment we have given, the patient is likely to develop encephalopathy, and most of the time that is due to encephalopathy. This is for information what I have done a paper on this. Thank you.
Yes, thank you so much, ma'am. So FIGO tells us, as you correctly elaborated, that it has PPH management has a first response bundle and a response to refractory PPH, that is the second one, second bundle. And FIGO says that this incorporation of PPH bundle approach should be instituted at all throughout all the hospitals, and every health system needs to adopt a bundle, and there are many available for use. And this should be in place in every maternity hospital, and regular drills and training of all elements of the bundle, right from the arrival in the obstetric service to transfer at the higher level of care, should be taken into account. So moving on with the patient, the uterine tone was reassessed after immediate management. Well, it was well contracted, but there was a mild trickle. Her estimated blood loss was 1000 ml. Her vitals remained stable throughout, and urine output was maintained. So my question to Dr. Jesna Hassan is, like, what would you like to do now, ma'am? And what is the role of balloon tamponade? Dr. Jesna.
Good evening, all. Am I audible?
Yes, ma'am.
Yes, okay. According to the PPH bundle, we have to go by the first line. If the first line measures have not, if we couldn't arrest the blood bleeding with the first line measures, then go for the second line measures, like Dilshat madam had already, like balloon tamponade, anti-shock garment, and uterine compression. So in this case, this is a case of AFLP with coagulation failure. So simultaneously, we have to go on correcting the coagulation failure also. So we have to simultaneously order for the blood products and blood products, packed cells, platelets, and FFP, in addition to the other measures. So in case of uterine balloon tamponade, so what the WHO 2021 guidelines says is that we can go for a balloon tamponade only if we meet certain criteria, like we have the immediate recourse to surgical interventions, immediate recourse to a surgical intervention. If it fails, if the balloon tamponade fails, we can go for a surgical measures like laparotomy, and we have to always go for a first line measures after going to the balloon tamponade, and we have to continuously monitor the patient when the balloon tamponade has been used. We have to always see the patient if she is going for a deterioration, and if the balloon tamponade is not acting, then we have to go for the next step. And we have almost in our center we have almost replaced balloon tamponade with SR suction cannula. So we have in our center we have been using it, and it's been really useful, and we are not using balloon tamponade as of now, and suction cannula is a better alternative in case of atonic PPH, and we can readily see visualize how much blood is being lost by the patient.
Yes, thank you, Dr. Jesna. So you are using SR cannula, and that's a very good thing to hear. And as you rightly said, we would have moved to UBT, that is the balloon tamponade in this patient. And there are many available depending upon your institution. And we must then carefully, once balloon tamponade has been in place, after 12 hours, we must start deflating it at a rate of 20 ml per hour, and it's commonly kept in situ for around 12 to 24 hours. So Dr. Bhavya, my next question is that despite of uterine
Dr.
balloon...
Shiva, Dr. Bharti Rajshekar has raised her hand. She wants to add something.
Yes, ma'am. Dr. Bharti, please.
Madam, please unmute yourself.
Ma'am, please unmute yourself. Dr. Bharti, ma'am. Yes.
Yeah, I'm there. Thank you, Shiva. The one thing I wanted to tell here is, the first thing is, we know that she's a case of acute fatty liver of pregnancy with in labor. Hemoglobin is less. We have to be prepared. And of course, if you're in a tertiary care center, I think we need to include the team of the hepatologist, the intensivist, and these things, we have to do. And in case this patient is not in a tertiary care center, we have to make arrangements that she is shifted to a higher center for better management, because in smaller centers, we may not be able to manage this. And the second thing is about balloon tamponade. I would like here to reiterate that The suction cannula, which was elaborately explained by Dr. Samarthana, is a very, very good instrument which we use even at the slightest notion of some atonic PPH in the regular patient, which has very good results compared to the balloon tamponade.
Thank you so much, ma'am, for that experience sharing. So, as you rightly said, it has to be a multidisciplinary approach, and everything has to go simultaneously. So, once balloon tamponade is in place and patient still continues to trickle, so Dr. Bhavya, how should we manage the coagulopathy and what we should do next?
Hello, everyone. Good evening. Am I audible, ma'am?
Yes, you are audible, Dr. Bhavya.
Okay, ma'am. When the patient is trickling, even after a balloon tamponade, as ma'am has told, we can switch on to our SR cannula or the suction cannula, which is much more effective than the balloon tamponade in arresting the bleeding from an atonic uterus. And we should be thinking of DIC now, that coagulopathy, the ongoing, means the upcoming coagulopathy. So we have to keep all the, we should inform our blood bank regarding the availability of ample amount of blood and blood products. So we have to keep the PRBC, packed blood cells, and fresh frozen plasma, cryoprecipitate, as well as platelet in adequate quantities. And we should explain to the bystanders as well and the caretakers regarding the need for blood transfusion and the impending coagulopathy. And we have to be ready for the correction of coagulopathy. We have to use packed blood cells and fresh frozen plasma, cryoprecipitate, and a platelet, and the ratio 1:1:1. And we should again recheck coagulation profiles, whether it is corrected or not, and we have to check whether the bleeding is arrested. Usually, when we correct the coagulopathy, the bleeding usually gets corrected, and on using the suction cannula, usually the uterus gets contracted and the coagulopathy will be under control.
Yes, thank you, Dr. Bhavya. So it has to be a multidisciplinary approach, blood product transfusion and coagulation factor depletion in patients with bleeding or those requiring any intervention after even the balloon tamponade has failed. As Dr. Bharti ma'am had already highlighted, that if the patient is not in a tertiary care center, we must think of referring the patient, and we can adopt the temporizing maneuvers till then, like bimanual compression to continue, and the pneumatic anti-shock garment comes in rescue in such cases. And as we already said that DIC management is the key, but we must also think that we must replace the blood platelets and coagulation factors, but we also should avoid hypothermia and acidosis because that will worsen the prognosis of the patient. And we should also aim at maintaining the oxygen saturation at more than 95%. So component therapy, we must go with the component therapy. So we have the triggers and we have various components. And we start with the ratio 1:1:1, and our FFP, platelets, everything is given. And if fibrinogen drops below 200, then we must go for cryoprecipitate and fibrinogen concentrate. So the targets for treatment are that hemoglobin should be more than 7, platelet count should be more than 50,000 per microliter, fibrinogen more than 300 milligram per deciliter, and the PT and APTT should be less than 1.5 times the control. So we have the experience of using fibrinogen in our institute, where FFPs and cryoprecipitates are used to correct hypofibrinogenemia traditionally, but to increase fibrinogen concentration by at least 1 gram per liter in a 70 kg adult human, we would require around 1 liter of FFP or about 250 ml of cryoprecipitate. So that's a whopping amount. So for this, the fibrinogen concentrate, it comes to rescue. It has reported thromboembolic events when compared to recombinant 7A, and it can be stored at 4 to 8 degrees, but cost is a limiting factor and it is not widely available. So recombinant factor 7A, again, considering absence of studies, it has limited role in PPH because of the complications, and it requires an adequate hematocrit, and the prerequisites are fibrinogen should be more than 1 gram when it is to be used. So my next question comes to Dr. Nilofer. What are the precautions during delivery or cesarean section in such patients?
Good evening all. Am I audible?
Other panelists, can you please mute yourself?
Yes, Dr. Nilofer, you are audible.
Yeah, thank you. See, you need a high index of suspicion to diagnose acute fatty liver of pregnancy. Okay, and most over the exact severity of the clinical condition is usually underestimated. So that's the first thing. The second thing is these patients, they deteriorate rapidly because of the metabolic acidosis. So a multidisciplinary approach, which is already mentioned, you need intensive care from the hematologist, from the gastroenterologist, from the obstetrician, everything. The most important is the coagulopathy. So we should first is refer to the tertiary center. Informed and consent is more important. Well, we do our whatever we do has to be informed to the patient then and there, and her exact condition must be informed to the patient attenders. So what are the precautions during delivery means when she is already, if it's vaginal, make sure you do active management of third stage of labor because you always anticipate PPH, even though the labs don't reflect any sort of coagulopathy. And make sure you're adequately equipped with blood and blood products and avoid tissue trauma, like during episiotomy or something. If they actually need, you can give episiotomy. And if during cesarean section, go with the blood and blood products, minimize the duration of the surgery, always keep on replacing the crystalloids and colloids, and make sure there is perfect hemostasis after the surgery. Even though the intraoperative period is okay, the postpartum is also equally important. She needs vigilant monitoring, both the mother and the neonate, because it takes time for LP to recede. It takes 36 weeks for the all the metabolic acidosis subside, everything. So she, even the postpartum period, she has to be in the ICU, and all the vigilant monitoring of lab values has to be done.
Yes, thank you, Dr. Nilofer. You perfectly highlighted what the precautions should be taken. And one thing which we should emphasize is that in such cases, always a senior obstetrician should deliver a case of ALPLP because there is always risk of vaginal hematomas and severe PPH, intractable PPH in such patients. We must correct coagulopathy. We try putting in intraperitoneal drain during cesarean section. As you said, strict vigilance for 24 hours postpartum and hemodynamic monitoring should ensue. And we must aim to maintain her fluid and electrolyte balance. And we must also keep a vigilant eye for infection because these patients will even worsen with infection and risk factors for sepsis. So before we go on to the second case, I would take some expert comments from Dr. Bharti ma'am.
Well, I think she has explained most of it. But as she spoke about the documentation, I think the consultant may be very busy in attending to the patient. So it's very important that we have one more person who is writing the whatever procedures we're doing in the chronological order and talking to the patients and their attendants then and there, so they know that we are doing everything that we can to help the patient. So this documentation in chronological order done by somebody else, and have a team where somebody does the talking. There's somebody else who's going to do the counseling and somebody else who's going to do the arrangements, and we are concentrating only on the management of the patient and keep them updated and never take things for granted when you document and discuss with them. This is very, very important because in the enthusiasm to save the patient, we forget, and sometimes when there is a casualty or there is some complication, our documents are not in place. And in spite of us working so hard to save that woman, we get into litigations. So
Yes,
always have your friends with you. Please call and have a lot of friends around you. We need as many hands as possible in such situations.
Ma'am, actually, I would like to add one more thing. Ma'am, we need not rush up emergency running around and doing a cesarean section. We could take that time to correct the DIC as early as possible, and then we can shift the patient to the theatre if time permits. There is not much of emergency.
Shall I add something here?
Yes, sir.
I think, no, am I not disturbing you?
No, sir, please go ahead, sir.
No, recently I happened to meet the professor, retired professor of Rajaji Medical College, Madurai, where I conducted 2 hands-on training workshops. No, recently there was a conference at Cochin. She came and she was chatting with me. She was telling every year there were 20 maternal deaths due to PPH because not only from the inside hospital, they were referred from outside with massive PPH and they died there. Like that, there were 20 maternal deaths every year for so many years. Last year, there was no single maternal death because SR cannula was being used in peripheral centers also. There was no single death. That's what she was sharing information with me. That's one thing. Second thing, we did first hands-on training workshop at the SUMC, Sri Venkateswara Medical College, Tirupati during 2018, August. So from there, around 4 or 5 batches of postgraduates came out. None of them have seen the B-Lynch procedure. So even laparotomies are disappearing. And what I would like to say, don't wait till massive bleeding occurs to measure the bleeding, to count the bleeding, visual estimation. What I'm telling you, just I'm not telling that SR cannula is great, but you have to save the mother. That's the first thing. Insert cannula, and cannula must be there in every hospital, I tell you, even a PHC. Even what we tried in Chittoor district, no, we trained MBBS doctors also. In this sense, even though they are not obstetricians, even though they are not conducting deliveries, these doctors will go and train the staff nurses there, so that by the time the doctor reached there, already cannula was inserted and the bleeding is stopped. This is one thing. Third thing I would like to share, in a critically ill patients like HELP syndrome or acute fatty liver of pregnancy or accidental hemorrhage, patient in massive coagulation dysfunction, what you have discussed now. So in such cases, no, the only one factor which makes everything worse is the bleeding. If you apply cannula and stop the bleeding, no, most of the trend to maternal death will come down, and we can buy time because blood loss is not there. So you can correct the coagulation defects, and it is possible to save many mothers. This is what I would like to share with you. And thank you very much.
Thank you so much, sir. And thank you, Dr. Bharti ma'am, for those vital inputs. So quickly going on to the second case. She was a para 1 live one with previous vaginal delivery 12 hours back. Was referred with history of traumatic PPH, cervical and vaginal lacerations with PAC in situ as per the referral paper. On examination in casualty, she had tachycardia to the tune of 120 per minute. Her blood pressure was 90/65. Her respiratory rate was 28 per minute. Saturation was 97% on room air. And she was pale with looking around 6 gram%. On per abdominal examination, the uterus was 20 weeks size, well contracted. On local examination, her PAC was partially soaked, which was in situ. So my question to Dr. K. Sundara Meenakshi, ma'am, please outline broadly the steps of management in such patient who is referred to us with traumatic PPH.
Ma'am, she is a case of traumatic severe PPH, ma'am. It is not mild PPH because BP is 90. So my 90 is 60 in both. The estimated blood loss should be at least 1,500 to 2,000 ml. So this patient, entire PPH drill has to switch on. Emergency team has to be alerted, and airway, breathing, circulation, everything should be managed. First, immediately, this patient, an informed concerned and the high risk concerned and about the present situation has to be explained to the attender by one member of the team. The other member, you have to call for the emergency anesthesiologist, intensivist also available there. Another thing, 2 wide bore needle has to, inflon has to be put for this patient, and you have to take blood samples, 20 ml blood samples to send all the investigation profiles. And then the patient should be placed with 10 liters of oxygen. You have to put a Foley catheter, empty the bladder, and then you by the time then you can shift the patient to the theater with good lighting. You can explore for any tears and anything else inside.
Yes, thank you, ma'am. So the immediate response bundle of PPH comes in place, and we must take consent for vaginal and cervical tear repair as per the notes, and laparotomy as well if required, and in rare case hysterectomy as well. So we must take the patient to OT, and under adequate anesthesia only we must attempt to take out PAC. This is a main thing which we ask or reiterate in front of all the postgraduates who are attending this or the budding gynecologists, that the PAC should never be attempted to be removed, no matter how tempted you are in the casualty there. It should always be done under OT, under anesthesia, in OT under anesthesia after arranging adequate blood products, and exploration and proceed accordingly should be done. So cervical exploration was done in this patient, and we saw a cervical tear of 6 to 7 centimeter at 6 o'clock position, and a right lateral vaginal tear was seen, but apex could not be reached. So my next question to Dr. Dilshat, ma'am, how should we manage the situation now, ma'am? Dr. Dilshat.
So when, hello?
Yes, ma'am.
So On examination, you have said that the apex of the cervical tear and the lateral vagina was not visible. It means that it extended into the pelvis. So even it might have involved the uterine, but if it is uterine means there will be the patient will be still more in a collapsed state. So what we have to do, we have to plan for laparotomy. So we have seen patients who are coming on the next day with the, when we examine, we can easily make out broad ligament hematoma with the lateral wall tear of the uterus. So laparotomy is the one which is indicated. Apart from the general measures, we have to improve resuscitation, simultaneous resuscitation, and do all these things.
Yes, correct, ma'am, because it was such a tear which was the apex would not visualize. So we had to resort to laparotomy in this patient. And after resuscitating, so laparotomy was done and a big broad ligament hematoma of around 6 to 7 centimeters was seen on the right side. So Dr. Jesna Hassan, can you enlighten us that how should we tackle this operatively, and what would be the challenges which we should anticipate, or what are the alternatives if available?
So this is the case of traumatic PPH. Am I audible?
Yes, you are audible.
Yes. Okay. So this is the case of traumatic PPH with colporexis and a very large broad ligament hematoma. So on laparotomy, we have to after laparotomy we have to evacuate the hematoma, and simultaneously we have to give the blood and blood products, and the simultaneous the correction of blood loss should go on, and the treatment of the problem per se is to remove the hematoma and secure the bleeding vessel. So the bilateral uterine arteries can also be ligated, and after uterine artery ligation also, if she is continuing, she goes on bleeding, then we can then always involve a senior obstetrician. We have to inform. We have to always call for help, and the senior obstetrician should be involved. And bilateral uterine artery ligation can also be done. And if she's still going on bleeding, we can even go on to hysterectomy, obstetric hysterectomy.
Yes, correct, Dr. Desna. But for sparing the uterus, we can always resort to one procedure which was very well highlighted by Dr. Manjupuri in her videos. That is the internal iliac artery ligation, which must be in the armamentarium of all obstetricians because it decreases the pulse pressure by 77 to 85%, reduces the blood flow, and it permits clot formation, which does not dislodge. And this is quite efficient procedure if done in time and effectively, because there are abundant collaterals which continue to supply blood to pelvis, and this becomes become functional 45 to 60 minutes, and her uterus is preserved and reproduction is not affected. So the procedure of IL has already been explained, and there are some complications as well. So Dr. Bharti ma'am, if you want to give some inputs for this case.
Yeah, well, as you rightly said, we have to be prepared for laparotomy and do the stepwise ligation first, uterine artery, ovarian artery, and if it doesn't stop bleeding, we will go for internal iliac ligation. So for internal iliac action, I think it's time that all our the obstetricians and the postgraduates need to be trained either on a simulator or in the clinical workshops that Foxy organizes, and we have to become confident in doing internal iliac ligation, because what was happening in the days of our postgraduate days, internal iliac ligation, we either would call the oncologist or we call the urologist and ask them to do it. I think it is a very simplified procedure. It is only the fear that we people have in our minds. We gynecologists and obstetricians can do much better. So we should overcome that and get trained in doing this simple procedure, because once you start doing it, it is a very simple procedure. So that's
yes, ma'am, correctly said. So simulation training is the need of the hour for IL, and then all the obstetricians, they can be made well versed for this procedure, and it definitely saves the uterus and the future reproduction of the patient. So thank you, ma'am. So proceeding to our last challenging case for the evening. So she was Mrs. X, 25-year-old, unbooked para 1 live 1 A3, who was admitted to gynae emergency on postnatal day 8 of preterm vaginal delivery with complaint of pain abdomen since 2 days, bleeding per vagina since 2 days. She was soaking 4 to 5 pads to fully associate the passage of clots. She had history of 3 spontaneous abortions in her first trimester each, followed by dilatation and curettage. And her last delivery was also a preterm birth at 32 weeks, where she delivered a 1.6 kg baby who was kept in nursery for quite some time. So on examination in casualty, her general condition was fair. She was afebrile, her stable, she had stable vitals, and she was clinically pale to the tune of 7 grams. For abdominal examination, no evidence of any organomegaly was seen. Uterus was 16 week size, well contracted. On first speculum examination done in emergency, mild bleeding was present through the os, but no clots were seen. Third vaginal examination was also done. It was a parasos. Uterus was corresponding to 16 week size, anteverted mobile, and bilateral cornices were free and non-tender. So we admitted her for observation in ward. Her routine investigations were sent, which came to be normal, except her HB, which corroborated to 7.2 grams, as expected. Her ultrasound pelvis was done, which was suggestive of a postpartum uterus with heterogeneous collection of 6 into 3.5 centimeter on the posterior wall with increased vascularity, whereas bilateral adnexa was normal and there was no free fluid in the pouch of Douglas. So this was the ultrasound picture, which showed a heterogeneous collection of 6 to 7 centimeter in the posterior wall with increased vascularity. So my first question to Dr. Bhavya, what is the differential diagnosis for this case? How would we proceed to manage this case? If we say, should we proceed for DNE directly? And if we proceed for DNE directly, what would be the risks in that case? Dr. Bhavya.
Yes, ma'am. This patient, she reported after a preterm vaginal delivery on postnatal day 8, and she had a hemoglobin of only 7 grams. So definitely she had a postpartum hemorrhage, which had led to this much severe anemia. And now her uterus is well contracted, 16 weeks, but her ultrasound shows such a finding with a vascularity 6 centimeter collection. So my provisional diagnosis in this case would be retained products of conception. It could be she's giving a history of recurrent DNCs previously, and now having a preterm vaginal delivery. So there is all the more chance for retained products, maybe a cotyledon or a chunk of placenta being adherent to the uterus, and which would have remained there and caused this problem for this lady. In this case, another differential diagnosis could be a uterine arteriovenous malformation, could be a pseudo malformation also because of the previous recurrent dilatation and curettage. And for this diagnosis should be made, actually the diagnosis should be made with ultrasound, which shows a lesion with an increased vascularity. But in case of AV malformations, you can use help of an interventional radiologist too, because you cannot go in for a dilatation and evacuation at a stretch. So in this case, first you have to correct the anemia. Her uterus is well contracted, so since her HB is only 7 grams, the anemia should be corrected first with blood and blood products. And any chance for sepsis, but her vitals or everything is stable, so a chance for sepsis, but there should be ruled out by putting her all investigations should be done. And another DD is gestational trophoblastic disease, which can, even though it is rare, it can happen. If we going for the fourth question was it if we going for a DNC directly, in case of doing a DNC directly, we may means dislodge the placenta and cause more bleeding, and it may end in brisk hemorrhage.
Yes, correct, Dr. Bhavya. So, as you rightly said, so the diagnosis was a vascular RPUC or adherent RPUC, and the other differential diagnosis kept in mind were AV malformation and GTT as well. So, uterine artery embolization, because it was available in our institute, followed by suction evacuation, was done in this patient the next day. And uterine artery embolization is a very non-surgical, minimally invasive technique which has to be done, however, in hemodynamically stable patients. And it has a high success rate of 95%, where gel form or PVA particles are used and with minimal complications. So, Dr. Nirosar, what are the indications of uterine artery embolization in PPH and any complications of uterine artery embolization? And what would be the outcome for future fertility, particularly in this patient, since she had one preterm vaginal delivery and her previous 3 were abortions?
Okay. So, to look at indications for uterine artery embolization in PPH, mostly we have done for atonic PPH. If the patient is hemodynamically stable and if the intervention radiology department is available and everything SS is there, in case of severe atonic PPH without onset of DIC, uterine artery embolization gives excellent results. Then coming on to in this case, because she has history of 3 DNC, so my suspicion goes in favor of placenta preta. Could be there. So in that case, if we don't do uterine artery embolization, again the risk of secondary PPH is high. So to avoid that, uterine artery embolization is best followed by suction and evacuation. So secondly, moving on to the complications of UAE, as such, there are no complications. I cannot say it's very minimal complications, especially when uterine artery embolization is preceded by compression sutures, then there is chance of uterine necrosis because our pelvis has massive collateral circulation. So almost the circulation gets re-established by a span of 10 days. And as we all know, the gelatin particles, it gets resorbed gradually within 10 days. So by average of 5 to 6 months, fertility is restored. And there are also centers who has analyzed ovarian blood supply following uterine artery embolization, and we have found that even the ovarian blood supply is not compromised with this uterine artery embolization. So as such, it is mainly the procedure-related complications and not actually due to the procedure. So in this patient with regarding the future fertility, she has already had 3 abortions and now adherent placenta. It's better to advise some sort of contraception.
So one thing to add.
We must allay her fears that pregnancy after uterine artery embolization, even the long-term effects are not known, but they're still reported. And the largest trial which we have, which was conducted over 555 women who went on to conceive after uterine artery embolization, attempted to conceive, 21 conceived and 18 live births were there. So women are able to achieve pregnancy after the embolization. However, non-availability at all places of uterine artery embolization for intervention radiologist is a concern. And the other thing is that it can be only done provided the patient is hemodynamically stable. So success rate is very good and it's a minimally invasive surgery procedure otherwise. But as you had very well highlighted, that only immediate complications, which are procedure related complications, and very few late complications. And the main complication which we have is the post-embolization syndrome, which also has to be managed conservatively, where patient might experience pain, nausea, fever, and malaise, which is often self-limiting within 10 to 14 days. So, Dr. Bharti ma'am, for expert inputs for this case.
Well, Dr. Shiba, the same, just what patient you presented now, I have one in my hospital right now. She is a cesarean, 20 days back, primipara, and unfortunately her serum creatinine is high. She's having sepsis. So we have, because we don't have uterine artery embolization in my setup. So the scan showed either AV malformation or retained product. So we have referred that patient because I don't have the facility. I'm not going to just immediately put a histoscope and try to do an evacuation. So we have told them that they have to go to a center with uterine artery embolization. So I think we people should not rush into procedures just because the patient has come to us and we don't want to refer them. Please handle only what you can handle in your center and try to refer them, and people will be there. Facilities are available at a short distance, maybe 2 hours journey. Let them go there and get the treatment according to the protocols. Please practice safely with protocols in whatever situation you may be.
Correct.
The days where we can say, because the patient says, I can't go to the higher center, I can't do this, that okay, let's try to do something. Please do not try to do something if you are not sure and you know that you may land up in problems. You never know when lightning is going to strike you.
Yes, ma'am. We must back our competency, but we must also think of whether we have that expertise or not, especially in this era of litigation. So, ma'am, my further question was that in all the three cases, once the PPH stops, what we should do. This was supposed to be an open house with expert inputs. So anyone can take this. Ma'am, though, has already highlighted about documentation. So what all we should do once the PPH has been managed in all these cases. So these were the three challenging real-time cases which we had at a sub-region hospital, which we shared. So anyone can take this question, like what should we do apart from documentation once we PPH is managed in these patients?
Ma'am, once this PPH is managed in these cases have to be watched very vigilantly in obstetric care. Every 15 minutes, the patient has to be monitored initially for the at least first 4 hours. Then after 4 hours, every hour the patient has to be monitored to be more close. Actually, we can monitor the patient every 15 minutes for 1 hour, then every hour for the entire 4 hours, then every 4th hourly for the next 24 hours. But because all of these patients had exclusively that DIC patient, she requires more vigilant monitoring. Number one. Number two is that these patients who are treated with coagulation factors and FFPs and all those things, these patients are most likely to get into thrombotic events post-operatively, and that has to be managed. And these patients have to be given thromboembolic stockings, and even DVT prophylaxis have to be thought about in these patients once the coagulation disorder has settled.
Yes, very well said, Sundara ma'am. So we must take into consideration whether this patient requires intensive care. Yes, she would require. So where is she going after we have managed her well? Then what we could have done better, like debriefing with the team should be done apart from documentation, which Bharti ma'am highlighted is very important, because so many times we get busy with managing and we forget about documentation. We should not, and we should retrospectively, chronologically jot down all the details, what all we did and what all could have been done. And then what questions does the patient relative have? We must think of answering even them. So the family needs the support. Their questions should be answered honestly about the patient's prognosis, about the care she would be getting further, and what did we forget. So that is very important in introspection. So we must consider anticoagulation. We must redose the antibiotics as Sundara ma'am has highlighted, and we must think of all the immediate and the late complications which might occur in this patient, including the survivor's guilt, the post-traumatic stress disorders which these patients generally have when they suffer from severe PPH, and then they undergo so many interventions and then go to the ICU apart from anemia management. So to summarize, PPH, so as we have already discussed, hemostasis, the FIGO, the E motive, as Dr. Sundara ma'am highlighted, we must be ready. We must not panic ourselves. Blood loss estimation should be done. Etiologies of bleeding should be kept in mind. We must estimate blood and fluid replacement. The drugs should be in hand. The intraoperative management should be taken. We must embark upon them as soon as the first response fails, and we must also get support during and afterwards. So we must earlier resort to subtotal or total hysterectomy if the patient is deteriorating and should not wait. So the FIGO has also said that every unit should be ready for managing PPH with all the infrastructure, the hemorrhage card, immediate access to hemorrhage medications, a response team to call when help is needed. Massive and emergency release transfusion protocols should be in place, and unit education on protocols and unit-based drills periodically should be taken. Then they all must be versed with recognizing and prevention of PPH. So assessment of hemorrhage risk, measurement of cumulative blood loss, which is clinical, should be taken more into consideration than just visual assessment, and active management of third stage of labor for prevention of PPH with department-wise protocol. Once PPH occurs, response should always be there. A standard stage-based obstetric hemorrhage emergency management plan should be in place with checklist in every hospital, whether it's a primary care center or a secondary care center or a tertiary care hospital. And then support program for patients, families, and staff for all significant hemorrhages should be in place. Counseling is very important for them. And then once we have finished with saving a patient, reporting and system learning should be done. We must establish a culture of huddles for high-risk patients like these and post-event debriefing sessions to identify successes and opportunities, what we entail and what we missed. A multidisciplinary review of serious hemorrhages for system issues should be done, and outcome monitoring and process metrics in perinatal quality should be there. So PPH is a serious life-threatening obstetric problem, forerunner in all near-miss audits, and the responsible for fearsome Ts are torn tissue trauma and thrombin. And the major cause of mortality and morbidity is too little if done too late. So the golden hour, as Jyotsna ma'am had highlighted, is pivotal even in the management of PPH, and resources of even well-equipped and staff units may be stretched at times. We must avoid the common mistakes. So the staff should be familiar with the protocols. Before hours, we must be ready. It should be a teamwork and communication should be there. And network integration is also required, and data monitoring and quality improvement should be there. So however difficult life may seem, there is always something we can do and succeed at. So with that, I would thank you all for the patient hearing, and thank you all the panelists and Dr. Bharti ma'am as well for that wonderful interaction and an academic feast. Thank you, ma'am. And thank you, Dr. Sadhana ma'am, for giving this opportunity.
Thank you. Thank you all.
Thank you, Dr. Shiba and Dr. Jyotsna, for that lively panel discussion, and a big thank you to Dr. Bharti madam for your expert comments. Sadhana madam, your concluding remarks.
Yes, thank you, Shiba and Dr. Jyotsna once again, and I thank everyone, Nizamabad, Karimnagar, Erode,
Adur,
Madurai, Salem and Adur Society, that you have given the date, and we are together, and always we learn a lot from each other. Every time we learn a lot, and we come to know that what is happening in different parts of the country. So once again, I always remain with us because I want to listen everyone. Thank you, Dr. Samartha, Dr. Manju Puri, Dr. Jyotsna, Dr. Shiva, for always, like, we are always being together, and Bharti, wonderful. She's like one of our very favorite expert, Dr. Bharti Rajshekhar. Like, I will just communicate, like, she's one of the very like a key person. She organizes so well. She is always proactive and excellent in knowledge and experience, and very what you say that I have to refer, and we are like having the same patient, and that actually makes us confident that how these case discussion actually make us very confident. So thank you once again, and like, thank you all the August viewers who are with us. Still we are around 45 minutes late, yet we have a very good attendance, and a big thank to Shailaja, because she is and this is something we discovered. Shailaja is so organized person, and she takes all the responsibilities for all phone call. And sometimes I wanted to have to call everyone, but sometimes it is not possible. So we have to rely the people like Shailaja for all the programs. So we have and I was in Karimnagar, and many of like Karimnagar members must have been, like, we were there in the meeting, as well as Salem in the South Junior of Oxy. So two society I have visited personally, and it is always very good to be together. So thank you once again. And we are also having cesarean workshop, and adolescent health, and the reproductive endocrinology workshop. So any whenever, if you want any program with your society, we are always there, and we will make a very good updated program with also involvement of all faculties from your society. So thank you once again. Thank you once again very much. And we look forward to great association.
Yeah, I was supposed to propose the vote of thanks. Dr. Sadhana Gupta madam has thanked all of us. A big thank you to
Shailaja.
Thank you, Dr. Sadhana, and wish you all the best and success.
Thank you. Thank you.
Ma'am, let your marathon race keep running, ma'am.
Shiba, and it's so nice to have so many young obstetricians and gynecologists, and it makes us feel very nice. Dr. Sundara Meenakshi, Shailaja, Shiba, all of you have done excellent. And thank you, Dr. Jyotsna. The panel was very good and useful, and so lively it was. I enjoyed every moment.
Thank you, everyone.
All young, we have the senior people, and we have all the young generation with us. So
good to see the young ones come up like that.
Yes.
Definitely.
I think Shailaja has lost the connection.
Yes.
She
was saying thank you to all, and Anyway, I think the connection got lost.
So we can, I have thanked already, and
Yes.
our chief guest, Dr. Sheelamani Sampath, and of course, all office bearers of all the 4 society, all faculty, all participants, and also the Shield Connect, who are doing a lot of program with us. And so thank you very much, Sahiti, and all the Shield Connect platform people, so for a wonderful coordination. So I think Sahiti, you can we can say goodbye, good night to everyone.
Yes,
And,
good night.
Yes, ma'am.